morning, everyone. I welcome you all this Sunday morning for the virtual conference on Pathways to Progress. With immense pleasure, I would like to invite Dr. Rajat Bajaj, who is Director and Unit Head Medical Oncology at Fortis Noida, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Yeah. Am I audible?
Yes, sir.
Okay. Good morning, everyone. I thank you all for joining this morning for this webinar, which is on the updates in oncology. We've had the day one of this particular event last week, and this is in continuation with what we discussed, some topics, and some of the other topics in GI are going to be discussed. We do know that these webinars and ensues between colleagues helps us to improve our understanding about the latest updates in our field and give the best to our patients always, and that is what we all as clinicians strive for. So I would like to start by inviting my first speaker for the day today, and he happens to be Dr. Utkarsh Gupta, who is a consultant in the Department of Pulmonary Medicine in Fortis Hospital, Noida. Dr. Utkarsh is going to talk about how do we really diagnose and screen for lung cancer in our patients who come to OPD, and what are the newer interventions that the pulmonologists are doing to diagnose these patients. And then, of course, as oncologists, we take over. So, Dr. Utkarsh, good morning. Can someone please confirm Dr. Utkarsh is there?
Dr.
Yeah,
Utkarsh,
Sarangni, please connect the call.
Sure.
Yeah. Dr. Utkarsh, good morning.
Hi, good morning.
Please take it over.
So I'll just share my screen. Just a second. Can you share my slide?
so, yeah, Dhruv, please share my
Just
Dr.
a
Sure,
Screen.
just a moment, sir.
Are my slides visible now?
Uh,
Yes,
yes,
sir.
sir, it is visible.
So hi, good morning, everyone. I'll be starting with screening, diagnosis, and management of early lung cancer. So I'm Dr. Utkarsh Gupta. I'm consultant at pulmonology and sleep medicine at Fortis Hospital, Noida. So screening means testing for a disease when there are no symptoms of history or history of that disease. Give a screening test to find disease early on when treatment may work better. So screening is a tool for early detection. Methods of early detection should have the highest yield among those at greatest risk of lung cancer. So it has major importance in the survival of patients with lung cancer. The stage at diagnosis is the primary determinant of prognosis, and prognosis is better and treatment more successful if disease is detected while still localized. So we first get an X-ray done, PA and lateral view. The sensitivity is dependent on the site and location of the lesion. The quality factor related to image skill of the interpreting physician, obscured lesion by the mediastinum, heart or diaphragm. We get a low dose helical CT scan done. It allows the entire chest to be surveyed in a single breath hold. So the time taken for the test is approximately 7 to 15 seconds. It reduces the motion artifact and eliminates respiratory misregistration. Narrow slice thickness. Hourly throughput is 4 patients per hour with a radiation dose 1/10 of the diagnostic CT. Chest CT is more sensitive than chest X-ray for detection of the early lung cancer presenting as small non-calcified solitary pulmonary nodules. So most of these lesions were detected in an early and thus resectable stage around stage 1A to 1B. So what do we mean by terms like GGOs? So GGOs are of three types: one non-solid, partly solid, and the solid lesions. So non-solid nodules with hazy increased lung attenuation, which does not obscure underlying bronchovascular markings, like we can see in the first image. Then the mixed are those nodules containing both GGOs and a solid component. And in the third image, we can see a solid with nodule with attenuation obscuring the bronchovascular structures. Uh, Down effects of the CT screening is radiation carcinogenesis, screening and consequent diagnostics like CT and PET CT scans. Additional minimally invasive procedures like percutaneous lung FNA, bronchoscopies, and VATs could be planned. Thoracotomy for benign disease. Is there an acceptable percentage? Mm, Potential post-operative morbidity and mortality, and treatment for disease without biopsy. So evaluation of other observations like cardiac, renal, liver, and adrenal disease. The diagnostic yield of sputum cytology is known to vary in relation to tumor location. It has the greatest use in the identification of the central tumors and is of little or no value in the identification of peripheral cancers. There is now evidence to suggest that its sensitivity can be much improved through the use of molecular genetics and immunocytochemical markers of malignancy. So, autofluorescence bronchoscopy is a technique that exploits the differences in the fluorescence properties of bronchial mucosa compared to mucosa of pre-invasive and invasive disease. Lung imaging fluorescence endoscopy system is the best known instrument. It uses a blue helium cadmium laser to illuminate the bronchial mucosa, and the resulting fluorescence is then digitized into a real-time video image. Other devices such as the D-Light autofluorescence system. Biomarkers, a large number of biomarkers have been studied for the early detection of lung cancer, including DNA, promoter hypermethylation, microsatellite instability, loss of heterozygosity, chromosomal aneuploidy, tumor-associated antibodies, tumor-associated antigens, proteomic profiles, messenger RNA, microRNA, and volatile organic compounds. These biomarkers have in turn been investigated in different specimens obtained by more or less invasive procedures, bronchial biopsies or bronchial alveolar lavage fluid, induced sputum, buccal nasal swabs, blood, plasma, serum circulating tumor cells, and peripheral exhale breath. An ideal early detection biomarker for large-scale screening should be applicable on easily accessible specimens through non-invasive procedures, have an easy and reproducible quantification, a high sensitivity and specificity, and a low cost. So few molecular markers are the changes in genes, gene products, and chromosomal abnormalities that can be used as biomarkers of pre-malignant conditions. Genes of RAS family, genes of HER2 is overexpressed in non-small cell lung cancers. P53 and RB are good candidate genes for detection by NT-sera or PCR. Chromosomal abnormalities have been reported in chromosome number 3, 11, 13, and 17. Endobronchial ultrasonography. This is a technique that allows view beyond the airway wall. So adding uh, endobronchial ultrasonography, commonly called EBUS, to white light or fluorescent bronchoscopy can significantly help in staging of lung cancer and early detection of mucosal changes and early invasion to submucosa. So there were nice guidelines that give access, which suggest the screening of lung cancer. So we look for the symptoms and signs. Go for an X-ray. If X-ray is normal and then and there's a low suspicion of lung cancer, so we just observe and manage the patient. If there is no suspicion or X-ray is not normal, we refer to a chest physician and members of the MDT clinical examination. We take history, blood test. If there are any signs of advanced metastatic disease, then we do a biopsy from the most accessible place. If there are no signs of advanced metastatic disease, and we suspect that there is no lung cancer, then we manage patient in the other way. If we suspect there is lung cancer, we go for a CT scan. CT scan is negative or inconclusive, we go for further scans like PET CT, surgical invasive procedures. If CT scan is have some kind of abnormalities and suggest evidence of advanced metastatic disease, we go for the biopsy, which is most accessible. If there are no evidence for the advanced metastatic disease, we look for any central or peripheral lesion. If the lesion is central, we go for a bronchoscopy. If the lesion is peripheral, we try a percutaneous natal biopsy. If patient is not fit for percutaneous natal biopsy, we try with the PET scan or surgical invasive procedures. If we are going for a bronchoscopy, then we uh, take bronchial lavage samples, we take the biopsy if there is any possible biopsy and wait for the results. We also, if bronchoscopy is not possible, then we try with a sputum cytology and look for the results. If we are doing percutaneous natal biopsy, then again we wait for the biopsy results. And if we have a positive result, then the diagnosis is confirmed. If by chance it's inconclusive, then again we go for a PET CT surgical, look for if any other surgical invasive procedure is possible. Diagnosis with or without histology. If histology is positive, then diagnosis is confirmed. If no, then we just further survey the patient for the disease. So summary, the X-ray should be ordered when lung cancer is a possibility, particularly when patients present with the following important early symptoms: hemoptysis, unexplained or persistent, cough, chest pain, and dyspnea for more than 3 weeks. Thank you.
Thank you, Dr. Utkarsh, for elucidating the role of screening in the diagnosis of lung cancer. Uh, if you talk about your experience, have you seen in the OPDs that patients come with a history of some early symptoms and then they are detected to have a malignancy?
Yes, sir. A lot of time, a lot many times. Sorry, patients come like vague symptoms. There are mild such as pain or cough, and when we do a chest X-ray, we find some kind of nodules over there. We screen patient with a CT scan, and there are some central or peripheral lesions that we can find. And when we go for a biopsy, so patient comes out to be positive.
Yeah.
Even patients of like young age, around 40, 50, are also getting detected in the early age these days.
Yeah, and now like we have recently opened up a lung screening clinic in our hospital. So I
Hmm.
think we are doing low dose CT scans more now to screen patients who are either having history of lung cancer or, of course, the smoking history of more than 20 pack years. And we all know that the NCCN guidelines recommend that a cutoff of 8 millimeter as a pulmonary nodule is to be kept. So hopefully this awareness is more and more in the society and we are able to catch this disease early so that these patients can be treated in a proper way early and can get cured. Certainly a pulmonologist plays a very important role. Pulmonologists are a very important part of our team to diagnose these patients and so that the oncologists can treat these patients well. So thank you, Dr. Utkarsh, for being here this morning and telling us about what is the role of the pulmonologist in aiding the oncologist in going way forward for lung cancer management. Thank you so much.
Thank you.
So now, after this talk, we move ahead to what has been new in the early lung cancer space as far as the use of immunotherapies is concerned. Immunotherapy has been there in lung cancer for years now, and we have all seen, used, and known how immunotherapy works magic in some of the patients in metastatic lung cancer space. But now, with the advent of neoadjuvant immunotherapy, it is even better for us to tell patients that there is a curative intent to our approach when we are treating lung cancer with immunotherapy. So, to talk about the same, we have with us Dr. Abhishek Yadav, who's a principal consultant in the Department of Medical Oncology at Yashoda Hospital in Koshambi. He's going to talk about the role of immunotherapy in early lung cancer space, especially durvalumab. Dr. Abhishek, good morning.
Good morning, Dr. Rajat. Am I audible?
Yes, yes, please take it forward.
Thank you so much for the invite. And seems to be a very interesting topic. I don't know how much we are using this approach in our practices, but the data seems to be very promising, as already told by you. So let me share my screen. Is my screen visible?
Yes, sir.
Okay. So the topic is integrating immunotherapy in management of early lung cancer, the oncologist's role in multidisciplinary care. So there's an unmet need to decrease disease recurrence and improve survival in resectable and SCLC. As we have seen in our practices that around 30 to 70% of patients, depending upon the stage they are initially in, they face recurrence following complete surgical resection. And the 5 year survival as per TNM8 edition, we can see as we progress from stage 1 to 2, 2A, B, 3, and 3B, the 5 year survival goes down. So from 1B to 3B, these are the potentially resectable patients with potential cure, but in them, we see that a significant number of patients face a relapse after surgery and the treatment. And so this was the target of many studies, that whether adding any new treatment or any new regime to the existing peri-op or neoadjuvant regimes can improve the survival. So slide is not moving.
So can we run from our side, sir?
Yeah, please, because I'm not able to
Not an issue. So Dhruv, can you
Sir,
scroll
please
just
these
a
move
moment.
it?
I'm
slides.
just sharing the slides.
Dhruv, please share.
I'm just sharing it. Just a moment. So it's visible?
Yeah, absolutely. Next slide, please. Yeah, next slide. So approaches to the management of resectable NSCLC, we know that it's not an individual decision. This decision has to be taken by a multidisciplinary team, which involves a pathologist, a radiation oncologist, a medical oncologist, a pulmonologist, and a thoracic surgeon. And there are many factors that have to be taken into care before planning the treatment, like pulmonary function tests, bronchoscopy, the FDG PET, pathological mediastinal lymph node assessment by EBUS or EUS, and a brain MRI with contrast. And the treatment can go from surgery to neoadjuvant chemotherapy or neoadjuvant immunotherapy plus followed by surgery, or surgery followed by adjuvant immunotherapy plus chemotherapy. Next slide. So there have been evidences of chemotherapy benefit in neoadjuvant and adjuvant settings, as shown by LACE meta-analysis of 5 trials, which shows that adjuvant chemotherapy with the platinum doublet significantly improves overall survival in patients with completely resected NSCLC. And the NSCLC meta-analysis collaborative group also showed that neoadjuvant chemotherapy followed by surgery for stage 1 to 3 NSCLC improves the 5-year overall survival by 5% as compared to the surgery alone. Next slide. So neoadjuvant and adjuvant immunotherapies have shown promising results with acceptable safety profiles. And neoadjuvant immunotherapy has several advantages, like potential for more robust and durable antitumor responses against micrometastatic disease than adjuvant immunotherapy, and potential for preventing immune tolerance and escape mechanisms that occur in early stage disease. Combining neoadjuvant immunotherapy and chemotherapy and further adjuvant immunotherapy is expected to improve activity and long-term clinical outcomes for patients with resectable stages 2 and 3 NSCLC, and the chances to treat patients who are not immunosuppressed, better treatment compliance, and decreased possibility of resistance due to limited exposure compared with adjuvant immunotherapy. And adjuvant immunotherapy in patients with resectable disease has an acceptable safety profile when used after adjuvant chemotherapy, and it has demonstrated a potential to restore anti-tumor immune activity after surgical resection, which we all know that surgical resection often leads to an immunosuppressed environment that promotes tumor metastasis. So adjuvant immunotherapy can break this immunosuppressive environment. Next slide. So these are the neoadjuvant and perioperative immunotherapy trials like Checkmate 816, which was nivolumab plus chemotherapy versus placebo uh, plus chemotherapy. The Keynote 671 was pembro plus chemotherapy versus placebo plus chemotherapy, 4 cycles, followed by adjuvant pembro for 13 cycles. And IM Power 030 was atezolizumab plus chemotherapy versus placebo plus chemotherapy, 4 cycles, and followed by atezolizumab 16 cycles versus observation. This was Checkmate 771, 770, which was nivolumab plus chemotherapy versus placebo plus chemotherapy 4 cycles, followed by nivolumab versus placebo for 1 year. The AGN study was for durvalumab plus chemotherapy versus placebo plus chemotherapy 4 cycles, followed by durvalumab versus placebo for 12 cycles. Rationale 315, that was tislelizumab plus chemotherapy versus placebo plus chemotherapy 4 cycles, followed by tisleli versus placebo for less than or 8 cycles in the adjuvant setting. And the neotorch was toripalimab versus plus chemotherapy versus placebo plus chemotherapy 4 cycles, followed by toripalimab maintenance for 13 cycles versus placebo. And we can see that most of these trials had an primary endpoint of EFS. EFS was common in almost all of them, and the other endpoints were pathological complete response. OS was only in the trial of Keynote 671, and the resection rates. Next slide. So if we come across a hypothetical case that we come across a patient who is 60-year-old female and is an ex-smoker with a history of 10 pack years, no significant comorbidities, incidentally detected with a lung lesion on chest X-ray PA view, done for cataract surgery in Feb 2022. CT chest was done immediately after that, and we could see a right lung mass uh, of 34 into 22 millimeter with bilateral emphysema with enlarged right hilar lymph node. Next slide. So, would you go for an NGS plus PDL1? Which strategies do you use for biomarker testing in the absence of an adequate biopsy or for the patients unable to undergo a biopsy? And would you do a brain scan? So, we see that brain scan was done, which showed no metastasis. PET-CT was showing a soft tissue mass lesion in the anterior basal segment of right lung lower lobe, and there was a metabolically active right hilar lymph node, and there were no distant metastasis. Patient had a decent 6-minute walk test and uh, the DLC of 46% and an FE1 of 73%. Next slide. So histopathology and molecular analysis was done. The biopsy was done, which was CTF1 positive. EGFR ALK were negative. PDL1 score was 40%. Mediastinal staging was done, and the only station 11R lymph node was positive for malignancy, and there were no level 2 lymph nodes. That is, N2 was completely negative, and the echo and ECG were normal. Next slide. This was the baseline imaging. Next slide. Next slide. So what is the stage of the patient? So this is we are dealing with I think T2A and 1. And what are the treatment options would you consider for this patient? Would you straightway like to go for surgery, or would you like to go for a new adjuvant chemotherapy or a new adjuvant chemotherapy plus immunotherapy? And what are your primary clinical goals and objectives regarding the use of perioperative chemoimmunotherapy in such a patient? Does the PDL1 score impact your decision? Yes, it does, depending upon what kind of immunotherapy agent that you are choosing. So, how do you choose the immunotherapy in such case? So, these are the interesting questions, which most of them we get an answer in the NCCN or the other recent guidelines. Next slide. So we see that durvalumab, pembrolizumab, nivolumab, and atezolizumab are all recommended in this setting of early NSCLC, and they all have shown benefit of EFS. And how to choose between them definitely is the clinician's experience, uh, depending upon what kind of results we each one of us have got in our practices, and the risk profile, the side effects, and then definitely PDL1 score is a very, very important parameter, because in case of durvalumab and nivolumab, I think PDL1 score was not, the benefit was achieved irrespective of the PDL1 score. But in case of atezolizumab, the benefit was not there in patients who had a PDL1 score of less than 1%. And in case of pembrolizumab, uh, the trial didn't make it clear whether this approach was beneficial for patients with a PDL1 score of less than or equal to 1. But in case of durvalumab, the benefit was seen in the patients who had PDL1 score of less than 1% as well. So irrespective of what kind of PDL1 score was there, the patients received benefit. And irrespective of whether the patient was in stage 2 or stage 3, the patients received a benefit. And so these are the baseline characteristics and planned treatment. So the baseline characteristics were very balanced between the study arms. I think the total number of 366 patients were taken in the durvalumab arm, and in the placebo arm, the number of patients was 374. Mostly patients got carboplatin-based doublet, that is more than 70%. And we can see that the patients with N0 and N1 lymph nodes were around 50%, and the patients with N2 lymph nodes were around 50%. And next slide, please. So, next slide. So this is patient disposition and treatment summary, and patients were randomized between 2nd January 2019 to 19th April 2022, with a minimum follow-up of 6.7 months. At the first planned interim analysis of EFS, median EFS follow-up in censored patients was 11.7 months, ranging from 0 to 46.1 months. So we can see that the study phase was basically divided into three phases: the new adjuvant phase, the surgery phase, and the both the arms were well matched in the terms of how many patients underwent surgery and those who were not able to undergo surgery. So around 19% of patients were not able to undergo surgery in both the durvalumab and the placebo arm. And in the adjuvant phase, we could see that the discontinuation rates were also similar in the durvalumab versus the placebo, that is 18 point, somewhere around 18%. So next slide. So updated EFS, that is the second planned interim analysis. EFS benefit favoring durvalumab arm was maintained and consistent with that reported previously. So the number of events in the durvalumab arm were 124 when compared to 165 in the placebo arm, and the median EFS was not recordable in the durvalumab arm, whereas it was 30 months in the placebo arm, and the hazard ratio was very handsome of 0.69, and we could see the separation of curves right from the beginning, that after 3 to 4 months of follow-up, the curves begin to separate, and the separation was maintained till the follow-up of 60 months from randomization. Next slide. So the benefit was observed in all subsets, whether what was the age, sex, ECOG performance status, race, smoking, whether the patient was a smoker, was a former smoker, current smoker, or never smoked, whether it was a squamous or the non-squamous histology, whether the disease was in the patient was in stage 2, it was in stage 3B or 3A, and what kind of lymph nodal stations were involved. Even the benefit was seen in irrespective of the type of nodal involvement, and the benefit was seen irrespective of whether the patient, what was the PDL1 expression at the baseline. Next slide. So now we come to the pathological response as per IASCLC 2020 methodology. We can see that the pathological complete response in the durvalumab arm was seen in 17.2% patients, and in placebo arm it was only in 4.3% patients, with a very highly significant p-value of 0.000036, and a difference was of almost 13%. The major pathological response, which is known as the less than 10% viable tumor left, was seen in 33% versus 12.3%. Again, the p-value was highly significant, with a major difference in the two treatment groups. Next slide. So to continue with the case, the patient received 4 cycles of neoadjuvant chemotherapy with immunotherapy, and the patient was reassessed after cycle 4 with a PET scan, and it showed partial response. Next slide. So this is the imaging of CT and PET at the baseline and after 4 cycles of chemoimmunotherapy. We can see that there is a very good response. Next slide. So again, the few questions that we need to ponder about, what would you consider reassessment for the patients after 4 cycles of chemoimmunotherapy? What is the goal of reassessment? When to you assess resectability? So after 2 to 4 cycles of treatment, and what assessments you usually perform? So I think it is very important to consider the reassessment after 4 cycles to see whether the patient has not progressed on the treatment regime and how much we have achieved, what kind of surgical approach we are going to take for the patient. I think these are the questions which are the goal of reassessment. And we all agree that the kind of assessments that we usually perform are CT and PET CT. Next slide. So planned treatment and surgery summary. So out of 740 randomized patients, uh, the 366 assigned to the durvalumab arm. Out of them, 84.7% completed 4 cycles of both chemotherapy and immunotherapy agents, and around 11 did not complete surgery. 284, that is 76.77% patients completed surgery. Reasons for not completing surgery, sorry, so out of 374 assigned to the placebo arm, 326 underwent the complete treatment of 4 cycles with both the agents, and around 76% patients completed surgery. 4% did not complete surgery. So again, the patients who completed both the regimes and were very similar in both the arms, and as well as the patients who could undergo surgery successfully were similar in both the arms. Next slide. So post neoadjuvant chemotherapy, we could see an attrition rate of around 20% in trials. So does that reflect when you see in clinical practice? What is your preferred surgery in early lung cancer patients? When do you consider pneumonectomy and other the minimal surgeries? So I think this is a very important topic that if patients are usually inclined to undergo a curable resection in the beginning in Indian setting, that was what I have seen in my practice. But we have to convince them that addition of neoadjuvant chemo and immunotherapy does make a significant difference. So this is part of the multidisciplinary team to take a decision and to convince the patients regarding its benefit. And what is the preferred surgery in early lung cancer patients? I think we all prefer the minimally invasive methods to or lobectomies rather than doing pneumonectomies in early lung cancer patients. Next slide. So approach and type of surgery by disease stage, those who underwent surgery. So we can see that in stage 2, around 39.5% patients underwent minimally invasive surgery versus 50% in the placebo group, and around 57 versus 47.9 percent underwent the minimally invasive surgeries, and open surgeries were done in around 40% patients in the durvalumab arm in stage 2 and in 50% in the placebo arm in stage 2. And in case of stage 3, we could see that the open surgeries, they increased in number from 39.5% to 53% in the durvalumab arm, but they stayed same in the placebo arm, that is around 51%. And the minimally invasive surgeries also, I think, reduced in the stage 3 which is expected in the durvalumab arm from 57% to 45.9%, whereas it stayed same, almost stayed same in the placebo arm. So I think the open and the minimally invasive were very well balanced in the both the arms. In if we leave the stages if we see in terms of all stages. Now, the type of surgeries, I think majority of the patients underwent lobectomy, whereas pneumonectomy was done in roughly 9% patients, and followed by other types of surgeries in very less number of patients. So majority of the surgeries that were done were lobectomies. Next slide. So what was the resection status by disease stage? I think 94.94% patients in the durvalumab arm underwent an R0 resection in comparison to 91% in the placebo arm, and there was an R1 resection rate of 4.2% and R2 resection in 0.7%. And in the durvalumab arm and in the placebo arm, it was 7.7% of R1 and 0.7% of R2.
Next slide. Sir,
So
sorry for
adverse
interrupt
events
you.
possibly
So
related to
kindly
surgery.
conclude your talk in 2-3 minutes, sir.
Yeah, sure. So adverse events, I think we are in the durvalumab arm were 119 and in the placebo arm it were 118. And the surgical complications were also very similar. So the adverse events and the surgical complication rates were not very different. Next slide. So will you treat patients not achieving PCR with further adjuvant immunotherapy? What are the factors influencing your treatment decisions? Would your treatment selection differ if the patient is N2 positive? If yes, how will you treat those patients? So these are the important questions that have to be considered. Next slide. So we can see that the PCR and the major pathological response in the baseline N2 subgroup, we can see that in the durvalumab arm it was 16.6%, and in the placebo arm it was 4.9% in the baseline N2 subgroup, and there was a difference of 13% in durvalumab arm with 17.2, and in the 4.3% in the placebo arm in the intent to treat population. So N2 single station, we can see the difference in the PCR rates was 13.9, and in the N2 multi station, the difference was less, significantly less, that is 3.8%. I think similar was observation was seen in the N2 single station and in the N2 multi station in case of the major pathological response criteria to 20.9% versus 1.8%. Next. So if we see the event-free survival, the baseline N2 subgroup, no events were seen in for durvalumab in 48%, in the N2 single station, and in the N2 multi-station, the hazard ratio was 0.69, and in the N2 single station, the hazard ratio was 0.61. So EFS benefit in this subgroup was consistent with the MITT population and similar among patients with single and the multi-station N2 disease. Next slide. So the patient underwent a mediastinoscopy, histopathological, showed a complete pathological response. Patient completed 12 cycles of adjuvant immunotherapy, no recurrence till March 2024. Next slide. So other trials in the similar settings are, next slide. So ASEAN, Checkmate, and Keynote, they all showed a benefit in the EFS as we discussed early. Next slide. So which patients do you, treatment outcomes for the perioperative trials? We can see that EFS was benefit was noted in all of them, and the PCR benefit was also noted in all of them. That is the Keynote 067, the Keynote 671, the Checkmate 770, and the ASEAN. Next slide. So the surgical outcomes, they were similar. The R0 resections were quite similar in all the studies. Next slide. So as far as safety is concerned, we can see that any grade immune mediated adverse events were more in the definitely the immunotherapy arms, and the all grade, if we see all grade adverse events, they were very similarly matched, and also the grade 3 and 4 adverse events were similarly matched in both the placebo and the immunotherapy in the treatment arm. Next slide. So, neoadjuvant versus periodic immunotherapy, how do we decide? So, we can see that it is a multidisciplinary approach. So, there are benefits of neoadjuvant approach and there are the benefits of adjuvant approach. Metastatic disease, increased treatment initiation rate and compliance, pathological complete response provides early indicator of response to therapy and can guide further treatment decisions, can potentially eliminate live tumor cell released into the circulation during surgery. For adjuvant approach, it allows the fastest time to surgery, no risk of pre-surgery complications from systemic therapy, no attrition, enables longer treatment duration for systemic control and more flexible timing post-surgery, provides more recovery time for the patient. Next slide. So these are the ASCO 2024 guidelines, which recommends MDT, and for the patients who have a ALK or EGFR mutation, the TKIs are the preferred regimes, and they should not be receiving immunotherapies. Next slide. Thank you so much. If there are any questions.
Thank you, Dr. Abhishek. So I think it is clear that uh, immunotherapy in early lung cancer also has shown benefits, and is adequate evidence. We have all used it in the metastatic setting. We have now started to use it in the in the neoadjuvant setting. Of course, the number of patients are on the lesser side because of less number of patients being diagnosed in the early stage. I think our surgeons also have understood that these cases should be discussed in the multidisciplinary tumor board, and also uh, should have the radiation oncologist also into play, because we have the option of a neoadjuvant chemo radiation as well. What is your take on the analysis which says that it is free of PDL1 approach in most of the data sets that we have seen? And also both smokers and never smokers both benefiting, at least in the AGN study that you presented.
Yeah, so this is something which I think the PDL1 status is not same for all immunotherapies. As far as the guidelines say, they say that in the checkmate trial, it was not clear whether the patient who have a PDL1 score of less than 1%, they actually benefited or not. And in terms of in the ATIZO trial, again, it was seen that the patients who had a PDL1 score of less than 1%, they didn't receive much benefit. So, but in the Durva and the Nivolumab study, they say that yes, irrespective of the PDL1 status, patients are getting benefit. And as far as you said, smoker and non-smoker, so this is a little bit, I think, surprising, or you can say that it is good to see that yes, both the subgroups were receiving benefit.
Yeah, right. I think it is all about choosing the patients wisely, and discussing it in the MDT approach is something clear from your talk. Thank you so much for presenting this topic very nicely. Thank you. So now we move
Thank you so
ahead,
much. Thanks so
and
much.
we are going to talk about the EGFR mutated non-small cell lung cancer. We all know that EGFR mutated non-small cell lung cancer in the last decade and a half has seen a wide range of treatment options coming to us, and along with that, an improvement in survival always has happened. We have had the only TKI approach that we have seen from first generation to second generation to third generation TKIs, but then now with the coming up of lot of scientific evidence as to what should be done more than only TKIs in this particular space of driver mutated non-small cell lung cancer, we see the coming in of TKI plus VEGF inhibitors, TKI plus chemotherapies. We have the bispecific antibodies coming up with TKI. So this space certainly has got more conglomerated in terms of newer treatment options coming up, and it probably is a nice headache to have for us as clinicians, and to tell our patients as to what all treatment options can improve the survival in these patients. After all, that is what we want as clinicians. So in the next 15 minutes or so, I would be talking about how do we optimize the management of advanced EGFR mutated NSCLC. Next slide. So, I thank Astra for giving me this opportunity to talk on the Flora 2 study, which was recently, which has come up in the last 1.5 years. I've been using it in some patients and have had good results. Of course, there are certain caveats that have to be understood and discussed well, is what I would like to cover in the next 15 minutes or so. We all know about EGFR mutated NSCLC since maybe 2000, early 2000s, that these are patients who are driver mutated patients. The most common actionable mutation that we have in NSCLC space. More in Asians as compared to non-Asians. Asians, the percentage of EGFR mutation in NSCLC can go up to somewhere around 35 to 40%, whereas our counterparts in US would say it to somewhere an extent of about 8 to 15%. That too, if they are lucky enough. Now, there are various reasons as to why Asians would have an EGFR mutation more than what we would see in our US population. But having said that, we also know that the most common EGFR mutations are either deletion in the exon 19 or they are exon 21 L858R point mutations. So the most common and the second most common in that order. And even the pie chart on the screen tells us the same. Next slide, please. Now, this is the landscape of EGFR mutated NSCLC treatment, which has evolved over time, and this is what I was talking about in my initial few statements, talking about early 2000s when gefitinib, which was the first generation EGFR inhibitor, which was approved by US FDA, to now 2018 and 20, talking about the approval of osimertinib, which is the third generation in the first line. And then, of course, now, like I said, that there is a combination approach that is now followed. We have come a long way, and not only that, the improvement in survival also has happened to the extent that we are able to tell patients that probably a survival in touching about 3 years overall survival is not a distant reality now in this particular space. Next slide. So, like I said, first generation, second generation, and third generation TKI. So, first generation is erlotinib and gefitinib. Second generation is afatinib and dacometinib, and third generation is osimertinib. The difference has been that the first generation were reversible binding to the wild type and the mutant EGFR, not very active on T790M mutation clones. The afatinib and dacometinib in the second generation have an irreversible covalent binding to the EGFR receptor, which have a broader activity in terms of overcoming the resistance mutations as well. But osimertinib in the third generation has got an activity, of course, for an irreversible covalent binding to the EGFR mutated patients or EGFR receptor, but also the specificity for EGFR T790M mutant clones as well, with a wild type sparing. So what it means is that a wild type sparing would actually mean that there is less number of side effects that were there with first generation and second generation, be it paronychia, be it skin dryness or dermal side effects, or be it the GI side effects. Next slide. Now, the progression-free survival, which has been the so-called endpoint mostly used in the trial, which have been done in this particular space, has improved over a period of time, with Dr. Tony Mock's IPAS study showing us a PFS of somewhere around 9 months in this particular mutation, to an Flora study by Dr. Ramalingam showing about 18 to 19 months in the blinded independent review. So, I think we've come a long way, almost a doubling of PFS, with the improvement of the number of therapies or the types of therapies that one has for to treat such patients. Next slide. Flora study showed that by far this was the maximum PFS as well as the overall survival. Of course, these are cross trial comparisons. One should refrain from doing that, but this is the best data set that we can have to make us understand that using an osimertinib versus a first generation EGFR inhibitor in today's era is certainly the need of the hour, because we want to give the best to our patients in terms of PFS and overall survival. Next slide, please. Now, like I said, that there is now a doublet or a couplet that is actually being promoted to treat this particular, EGFR mutated NSCLC, and it is not without reason. Certainly, the reason is to keep on making efforts to improve the survival. And in this particular endeavor, the addition of chemotherapy to EGFR TKIs has been tried first with first generation TKIs and now with third generation TKI of osimertinib as well. What has it really done is what we're going to talk about in the next few slides. Next slide, please. So we all know that the TKI combination trials were there, and these were initially started with first generation TKIs, and it showed that the PFS benefit was substantial. At times there was doubling of PFS which was seen, and the most talked about trial is the NEJ009 study in China, and our own TMH study which came in 2020 by Dr. Kumar Prabhash sir and et al. So there, the addition of chemotherapy to gefitinib versus gefitinib alone, like I said, that doubling of PFS, nearly about 16 to 17 months was the PFS. The overall response rates, they were about 75 to 80%. And in that particular trial, probably the OS was not really achieved, or it was reached. But then we do know that there have been trials where the OS has touched to somewhere around 45 to 50 months as well. So this is certainly a promising approach. There is scientific evidence to why we should be combining the two, even though one is sidal and the other is static, and well tolerated also at that. And I'm sure all of us have used that. It is an approach which is not very cumbersome for our most of the patients who would have financial constraints as well. Next slide. This is the TMH study that we're talking about, where gefitinib versus gefitinib plus pemetrexed carboplatin was studied in this particular clinical trial. And any exon mutated patients, be it 19, 21, or 18, were taken. Mostly were DEL 19, and treatment naive patients. Stratification also according to 19 and 18 and 21 was planned, and then they were randomized to either standard gefitinib of 250 milligrams once a day, or a gefitinib plus pemetrexed carboplatin in a standard dose, followed by pemetrexed maintenance according to the Paramount study, with primary endpoint being the PFS, secondary endpoint being overall survival, quality of life, and the response rates. Next slide. So it was seen that there was a PFS improvement. There was an overall survival improvement as well. One can see the PFS hazard ratio being 0.51, OS being 0.45, and the Kaplan-Meier curves separating widely till the very end is a good sight for an oncologist. Next slide. And even the benefits were there in the subgroups. If you look at the brain metastasis patients, they also benefited. Patients who did not have brain metastasis also benefited, and also in the exon 19 and the others also there was a benefit. Next slide. Response rates also, like I said, they were touching around 75%. So these waterfall plots tell us that a combination approach definitely did improve the response rates, with a beautiful forest plot that one can, beautiful waterfall plot that one can see on the right hand side of the screen right now. Next slide. So after the discussion on the TKI plus chemotherapy, where TKI was first generation, there was a constant effort to improve the PFS over and above what is given by osimertinib, and for that the effort was to bring in Flora 2. Flora 2 was osimertinib combined with chemotherapy to see whether one can achieve an improved survival compared to what was achieved only with osimertinib monotherapy. So this is Flora 2 design, and one can see that again treatment naive patients who were metastatic NSCLC, and these patients were could be having a exon 19 or an L858R mutation, good performance status with stable CNS metastasis were allowed. They were randomized in 1:1 ratio, and there were about 500 odd patients who were there in this particular trial, combined both the study arm and the control arm, and randomized to either osimertinib in the standard dose of 80 milligram per day or an osimertinib with pemetrexed carboplatin in the standard doses, followed by osimertinib plus pemetrexed maintenance. And the primary endpoint was kept as PFS, and the secondary endpoint was kept as overall survival, response rates, duration of response, amongst others. Next slide, please. These are the baseline characteristics. So, understandably, there were mostly patients who were never smokers, mostly patients who were adenocarcinomas, but importantly, 40% of the patients had CNS metastasis, which was stable at the baseline. So, I think fairly a well-designed study, and equal characteristics in both the study arm and the control arm. Uh, and tumor size also, mean tumor size also, significantly large tumor size, so akin to what we see in our daily practice. Next slide, please. So this is about the progression-free survival, which I told was the primary endpoint, and this is where we really would want to pitch in this particular combination of TKI plus chemotherapy, where we see that the median PFS in the control arm was somewhere around 17 months, which is equal to what we saw in the Flora study. So the control arm did well. So this is an indicator that it was a study which was well conducted, but the importance is a median PFS benefit of about 9 months that one can see, and the median PFS reached about 26 months. And not only that, one can see that the PFS was the benefit was consistently maintained over the 1 year first interim analysis and the second year interim analysis as well, with second year interim analysis at 24 months showing us a 57% versus 41% between the two arms. So it was a positive study, and the primary endpoint of PFS was maintained. Next slide. This is about the PFS according to the BICR, and there also there was an improved PFS. If you look at the subgroup analysis, so this also is always interesting to see as to if there is any subgroup which did not really benefit, but that also thankfully was not the case. So patients who had a DEL 19 versus L858R, both of them benefited. Patients who had a CNS metastasis at the baseline benefited, and that there was a huge benefit in this particular subgroup. One can see the diamond being majorly on the side of the study arm. One can also see that irrespective of the gender or the race or the smoking history or the age at screening, all of these patients did benefit. So it was a positive study where the PFS across the planned subgroup analysis in the forest plot also benefited. Majorly, the benefiting group had to be a patient who had CNS metastasis at the baseline. Next slide. Next slide, please. So CNS metastasis, I think, is the Achilles tendon that we have in treating such patients who are EGFR mutated. We all know that these patients would mostly do well in the extracranial space, but intracranial space, there are patients who would fail, and some of them would fail continuously there, and that becomes a major headache for us to treat those cases in a way so that the quality of life is maintained, and the survival at times is dependent on that particular treatment as well. So osimertinib has got a great CNS penetration. We all know, compared to the previous generation TKIs, there is ample evidence to suggest that. Next slide. But if we this is the Flora study again to show that the benefit was seen in patients presenting with CNS metastasis. There was a sad ratio of 0.47 with a intracranial PFS is somewhere around 15 to 16 months. Next slide. But if we add chemotherapy, next slide, did it actually improve the outcomes in patients who are having a CNS metastasis? So, drugs can enter the brain in brain metastasis patients, maybe not so much if the blood-brain barrier is intact, but if there is brain metastasis, there is evidence to suggest, which is both preclinical and retrospective analysis to suggest that in patients who are having a disrupted blood-brain barrier because of brain metastasis, the chemotherapeutic drugs can cross the blood-brain barrier and show a shrinkage of the tumor in that particular space as well. Next slide. And this is only chemotherapy in brain metastasis patients where some response has been seen in the intracranial domain, be it with platinum or pemetrexed. Next slide. This again was a Jefne plus chemotherapy trial which was done in brain metastasis patients, and here also an improvement in the response rates and the PFS was seen. Next slide. Yeah, so next slide, this we have discussed. So not only PFS but the overall survival also improved along with the chemo in the chemotherapy arm along with gefitinib as compared to gefitinib alone. Next slide. Talking about FLORA 2, next slide. So this is only CNS metastasis patients where we see that the early separation of graph was seen at 3 months. The median PFS, even in the CNS metastasis, was about 24 months versus 14 months, with a hazard ratio of 0.47, nearly the same as what was the hazard ratio in the FLORA study when osimertinib alone was being compared with gefitinib or erlotinib monotherapy. So over and above the benefit of using osimertinib monotherapy, one could see that osimertinib plus chemotherapy approach was showing improvement in CNS metastasis patients as well as patients where there was no CNS metastasis. Next slide.
Sorry, sir, to interfere. Just wanted to request you to conclude your presentation in next 2-3 minutes.
Yes, yes, sure. So I think this is the same data set to suggest that even in the full analysis set, there was an improvement in CNS PFS. Next slide. And higher complete responses were achieved with combination left hand side and the right hand side of the screen, which was presented in ESMO 2023. Next slide. So the combination also decreased the risk of CNS progression. Not only patients who benefited were patients where there was a baseline CNS metastasis, but if there was no CNS metastasis, even the progression was delayed. Next slide. Now, all the new combinations or the new therapies have to be seen from the aspect of their adverse effects as well. We do know that Jefne plus chemotherapy arm in the TMH study or the NEJ009 study had some hematological side effects which had to be expected when the chemotherapy was being used, but they were fairly tolerated well. But if we talk about the FLORA 2 study, here the hematological side effects and the diarrhea, they were certainly there, because of which there were some discontinuations in the treatment as well. Next slide. So, next slide. So, one has to understand that this particular combination has certainly shown the benefit which has been there, both in terms of PFS in the intracranial and the extracranial space. The overall survival is yet to be matured. Uh, we would certainly await the OS benefit if at all it comes in this particular combination. But the trade-offs have to be kept in mind. Probably this combination may not be for everybody. Patients who are fit candidates with the good performance status, where a hematological toxicity or dermal toxicity can be endured better than other patients, would be the patients where this combination approach can be given. Osimertinib monotherapy still would probably be a valid treatment option for such patients. And the reason for that is that osimertinib monotherapy, almost all of us have used. Not only we've had good results, but we've had a good quality of life being offered to the patients as well. And that is paramount since we are talking about patients who are having a metastatic disease and stage 4 disease. When we cannot cure, we are palliating. The quality of life certainly is important. But this is an important combination that one can keep in mind, should discuss and be offered to patients who are having a good general condition, so that nearly a 60 to 70% improvement in PFS benefit can be offered to the patients from now on in EGFR mutated NSCLC space. With this, I thank you all for your patient listening. So I think with this, we finish the lung cancer track and go on to the hepatobiliary cancers. To talk about the hepatobiliary cancers and the recent developments in the management of early and intermediate stage hepatocellular carcinomas, we have with us Dr. Sumit Goyal sir, who's a senior consultant and associate director in the Department of Medical Oncology at Rajiv Gandhi Cancer Institute in Delhi. Sir is there?
Oh, he is not there, so can we invite to Dr. Monica?
Yeah, sure. So I think maybe Dr. Goyal is going to join in some time. Till then, we can go on to the next topic, which is the integration of targeted therapy into the management of advanced BTC. And to talk about this, we have with us Dr. Monica Bopanna, who's a consultant in the Department of Medical Oncology at KIMS Hospital in Hyderabad. Good morning, Dr. Monica.
Good morning, Dr. Rajat. I'll share my presentation. I hope I'm audible.
Yes, you are.
Yeah. Is my screen visible now?
Yes, it is visible.
Yes, ma'am, make it full
Yeah.
screen.
I'll put it in the presentation mode. Yeah, so today we'll discuss about the integration of targeted therapies into the management of advanced biliary tract cancers. In India, if you look at the incidence, this particular data that we have, more than 30,000 new cases of BTCs being diagnosed every year. This is from a combined population-based cancer registry analysis. Data from a number of almost nearly 15 to 16 population-based cancer registries were analyzed. The data was analyzed, and we have more than 30,000 new cases of BTCs being diagnosed every year. And this incidence is very, very high. So global burden wise, India makes a significant contribution to the global burden. The crude incidence of gallbladder and gallbladder cancer and BTCs, it's in females, it's highest we know in the northern, the Indo-Ganges belt, the states of Assam, Delhi, Uttar Pradesh, Bihar. We see a lot of cases over there. And 90% of the BTCs, unfortunately, are diagnosed in the unresectable or advanced stage. And there has also been an increase in the incidence of BTCs in both males and females over the last few years. So almost 10% of the global burden of biliary tract cancers is contributed by India. The highest incidence is in the northern regions. The Indo-Gangetic plain, it's about 21 cases per 100,000 individuals. That's the incidence. So it's a very high incidence, and it's a female dominant disease. Now, in 2010, gemcitabine with cisplatin was established as the standard first-line chemotherapy for advanced BTCs because, as compared to gemcitabine alone, the addition of cisplatin showed a significant PFS as well as OS benefit. So, gemcis continues to remain the basic backbone of treatment of these patients. It remains still the standard of care, and not many newer therapies have been added which have made a very, very significant difference. There have been a few drugs, including immune checkpoint inhibitors. So let us look at that data now. Now, how about the addition of a third drug, that is nab-paclitaxel, for the treatment of advanced BTC? So this is a phase 2 clinical trial, and with the addition of nab-paclitaxel, there was a median PFS of about 11.8 months. So it was a small study with about 60 patients, and it found an overall response rate of 45% and disease control rate of 84%. So that is quite significant, but definitely the addition of a third chemotherapeutic drug means that there is addition of more toxicity as well. So do we routinely use a 3-drug regimen in a palliative setting? No, because it does not have any overall survival benefit. This trial, that is the SWOG 1815 trial, which is a phase 3 randomized trial of gemcitabine cisplatin with nab-paclitaxel versus gemcis alone in newly diagnosed advanced BTCs, failed to demonstrate any OS or PFS benefit. with the addition of nab-paclitaxel. So maybe in the neoadjuvant setting, when the response is a very important parameter, because somebody who's borderline resectable, we want to convert them to a resectable tumor, then is when probably we are justified in adding a third drug as well as the toxicity, but not in a palliative setting, certainly. So this is so basically it just leads to improved rates, improved resectability rates when we add it in the non-metastatic setting where it's a borderline resectable tumor. Now we have the addition of immunotherapy agents to the standard backbone of gemcitabine cisplatin. This was explored in 2 trials, Topaz 1 that looked at the addition of durvalumab, and Keynote 966 that looked at the addition of pembrolizumab to the usual standard GemCis regimen. An important difference is that in the Keynote 966 trial, gemcitabine was also continued in the as a maintenance phase till progression, whereas in Topaz 1, durvalumab was continued until progressive disease. There was no chemotherapy that was continued. So, both of them were placebo-controlled trials, and Keynote 966 included more non-Asian population, so it had a broader global representation as compared to Topaz 1. Now, if you look at the OS curves, there was a significant OS benefit that was seen in Topaz 1 with the addition of durvalumab. It was 12.9 months versus 11.3 months with a hazard ratio of 0.76, which was statistically significant. And if you look at the 2-year overall survival, it is 23.6% versus 11.5% in favor of the addition of durvalumab. Keynote 966, the median OS was 12.7 months in the pembro group as compared to 10.9 months in the placebo group, again with a hazard ratio of 0.85 with a statistically significant p-value. So even in Keynote 966, there was a statistically significant and meaningful improvement in the overall survival that was demonstrated with the addition of pembrolizumab to GemCis regimen. Now, if you look at the overall response rates from the Topaz trial, the overall response rates were also significantly superior. It is about nearly 25% are the overall response rates, with about 2% of the patients even showing a complete response as compared to the placebo group. And the duration of response, the median duration of response was also 6.4 versus 6.2 months. Not a very big difference, but there was a shorter time to response with the addition of durvalumab. An interesting thing to note in all of these immunotherapy trials is I don't have that kind of curves from Keynote 966, but if you look at the curves of the overall survival curves of Topaz 1 trial, it is seen that some patients who responded, a small percentage of about 10 to 12% of the patients, they continued to respond even beyond almost up to 3 years. So among participants with the best objective response of stable disease, there was a sustained separation between the curves at approximately 6 months. So this is the 3-year OS update of Topaz 1 and Keynote 166, both of them showing a good difference. Now, coming to maintenance therapy in biliary tract cancer. So there are a few studies which have demonstrated a benefit of continuing some chemotherapy or some therapy as a maintenance. So this trial looked at continuation of gemcitabine following any of the gemcitabine platinum-based regimens, whether it's GemCis or GemOx. And it was seen that some patients were there who, if tolerating the treatment well, their survival could be prolonged by continuing chemotherapy as a maintenance. Another interesting study from TMH is the BEER-BTC trial, where bevacizumab and erlotinib switch maintenance was done in chemo-responsive advanced gallbladder and cholangiocarcinoma patients. So this strategy showed a significant PFS benefit with a statistically significant p-value. This was a phase 2 trial. The number of patients was small, but compared to observation, once they've achieved a stable disease at least, whether it's a partial response, CR, or a stable disease, such patients were put on a maintenance regimen with bevacizumab given 5 milligram per kg body weight every 3 weekly and erlotinib 100 mg once daily. Versus observation, it was seen that the arm where bevacizumab, erlotinib were used as a maintenance, there was a significant PFS benefit. Now, GemCis versus GemOx, again, overall, if you see, the EFS is probably slightly superior with GemCis, but overall survivals are not different. They're just regimens with different toxicity profile. In patients who already have a lot of neuropathy, we would probably want to avoid GemOx and go for GemCis. those who have renal and cardiac tissues, GEMOX is a preferred regimen. So GemCis with or without checkpoint inhibitors is the current first-line standard of care for patients with recurrent locally advanced or metastatic disease. But this is a universal approach. It's not like a one-size-fits-all. This one-size-fits-all strategy upfront is challenged by the widespread heterogeneity that is seen in BTCs. All BTCs are not same. Even in cholangio, extrahepatic is molecularly different from intrahepatic. Gallbladder is molecularly different from cholangiocarcinoma. So there is a lot of heterogeneity, and these molecular, genetic as well as non-genetic differences play a very, very important role. So this regimen, which has emerged as a standard of care, that is GemCis with some immune checkpoint inhibitor, is not something that everyone would respond to. BTC originally emerged into the spotlight as a remarkably responsive to precision medicine approaches, in the various basket trials that were conducted. Very good response rates were actually seen with biliary tract cancers. There is a very high incidence of actionable alterations and therapeutic benefit when these alterations are targeted as compared to other cancers. So it is now very clear. Now we are at a point where biomarker-driven selection of BTC patients for targeted therapies improves the overall survival compared to those without, cementing tumor molecular profiling as fundamental to the care of these patients. So tumor molecular profiling becomes very important. Multiple biomarker-guided targeted therapies have emerged in the palliative setting after progression on the first-line standard of care, chemotherapy, or in patients who are unfit for chemotherapy. Current molecular selection of patients enriches for responders compared to the general population, but there are subgroups of patients who derive no therapeutic benefit from targeted therapies also, despite their tumors harboring the targeted alteration because of primary or innate resistance, or very quickly they become resistant, that is, they acquire secondary resistance mechanisms. So almost all of these patients experience progression at some point of time or the other on targeted therapies with a relatively very short time frame that's caused by secondary or acquired resistance mechanisms. So our current molecular criteria for patient selection are suboptimal. They require a more biology driven refinement. Who are the ones who are likely to respond for a longer duration with a certain type of targeted therapy is what we are very interested in. Now, if you look at HER2, because HER2 is something which we are very commonly targeting in BTCs and many other cancers also, amplifications, mutations, overexpressions, there are different alterations which can happen in HER2, and some of the highest amplification rates were seen in extrahepatic cholangio as well as gallbladder. The incidence is a little less in intrahepatic cholangio, it's just 5.2%, but in extrahepatic it's the highest, it's around 20%, and GB cancers it's about 17%. So there are primary challenges because there's so much of heterogeneity in assessment of HER2 also. Lot of heterogeneity in molecular analysis also. There's no uniformity globally, and that is one of the reasons why different incidences of these mutations or alterations are seen in different trials from different geographic regimens. Now, if you look at this, so this is the systemic therapy, the standard regimens. This is what we are interested in. That is the molecular targeted therapies. We have a lot of options. We have NTRK gene inhibitors. Then we have decisions to take regarding immune checkpoint inhibitors based on MSI or tumor mutation burden. BRAF V600E mutation is another thing that we target. FGFR2 alterations, IDH1 mutations, RET gene fusions. So these are there are a lot of, and HER2 gene alterations. These are the various molecular alterations which we see. Now, if you look at this, this is a very interesting diagram because it gives us the molecular alterations and the drugs. This is the objective response rate and disease control rate. So it's given as half glass full. So this is a more optimistic view. If you look at the molecularly targeting drugs, dabrafenib, tremetinib, and zanidatamab, which is a bispecific anti-HER2 agent again. And then we have futibatinib and pemigatinib, which are also the molecularly targeted agents. They are the FGFR2 inhibitors. So they show very good objective response rates and disease control rates approaching more than 80% with all these drugs. Trastuzumab is a little less than 80%. Zanidatamab also has disease control rates approaching almost 70%. Infigratinib is again another FGFR2 inhibitor. And if you look at the ivosidenib, that is the IDH1 inhibitor, this again, the objective response rates or the disease control rates are not that great with this drug. Pertuzumab trastuzumab combination also, we don't have very, very good disease control rates, but yes, that also is somewhere around 50%. So this slide gives us a very good overview of what are all the molecular targeted agents available, what do they target, and what are the objective response rates and disease control rates that we see. Unquestionably, intrahepatic cholangio, we have most of our data from intrahepatic because this is one BTC which has dominated the targeted therapy trial space, because most of the alterations are found in intrahepatic cholangio only. So if you look at all the trials which have very small numbers of patients, of just 40 patients or 60 patients, in most of them this is the dominant tumor which is there, that is intrahepatic cholangio. So if you look at, this is the table. So FGFR2 alterations are about 9% incidence in intrahepatic cholangio. Drugs we have are pemigatinib, futabatinib, and infigratinib. IDH1 mutation incidence is 14%. We have ivosidenib, but the overall response rates are not that great with this drug. HER2 alterations are there, as I said, 25% in gallbladder cancers, 18% in extrahepatic cholangio, and about 5% in intrahepatic cholangio. We have zanidatamab, trastuzumab, pertuzumab, tucatinib, trastuzumab deruxtecan, all these drugs. BRAF, we have dabrafenib, trametinib, NTRK fusions, entrectinib, larotrectinib, and repotrectinib are the drugs. So these are the various drugs which have been tried in BTCs according to the molecular alterations. Trastuzumab along with Gemcis for treatment-naive HER2 positive BTCs. This was a multi-center phase 2 study. This is also a TMH study, and this showed definitely a superior overall progression-free survival with the addition of trastuzumab to gemcitabine cisplatin. The 6-month OS, this is so this 6-month OS is about 81%, and the 1-year OS is about 39%. The median OS was about 9.9 months in patients where the median OS is about just 6-7 months. There's definitely a 1 to 2 month improvement in the overall survival. This is a phase 2 study, so it's a single arm study, and this is what was seen, that there was a very good OS as well as PFS benefit with the addition of trastuzumab. And 6.7% of the patients actually had a complete response, 49% had a partial response. So the combination of Gemcis and trastuzumab achieved its primary endpoint of improving the PFS. This was compared to the historical data. Again, that is definitely a shortcoming, but historical data comparison and comparing the historical data or overall survivals in PFS, there's definitely a benefit of adding trastuzumab. Zanidatamab is a humanized monoclonal antibody that's used for the treatment of HER2 positive BTCs. This is a bispecific HER2 directed antibody that's directed against 2 non-overlapping domains of HER2. Efficacy was evaluated in the Horizon BTC-01 trial, which was an open-label multi-center single-arm trial of 62 patients with unresectable metastatic HER2-positive BTCs. Patients were required to have received at least one prior gemcitabine-containing regimen in the advanced setting. The major efficacy outcomes were overall response rate and duration of response. Overall response rates were 52%. Median duration of response was nearly 15 months, which is very, very significant. So zanidatamab was approved for medical use in the United States in November 2024, and FDA considers it to be a first-in-class medication. Now, the problem with all these targeted therapies, as I said earlier, is that resistance emerges. There is primary resistance also. In many patients, we find that despite having the mutation, these drugs don't work. And the other problem is that they work for a very short span of time, even if they work. Currently, the precision approaches to target therapies, they require detection of a target genomic alteration, either in the DNA or its positive expression, that is in the RNA or protein in tumor tissue. But not all alterations in a target gene are created equally. There are different breakpoints in fusions. There are different amino acid substitutions at a mutation hotspot. And this heterogeneity is the one which actually undermines the therapeutic benefit of all these targeted therapy drugs. So we probably have to find out more mechanisms and understand the crosstalk among the various different molecular pathways and see how the resistance mechanisms emerge. There's a lot more to learn, and probably our knowledge, we can say, is quite rudimentary as far as molecular targeted therapies in BTCs is concerned. So we have a lot more to learn. Thank you very much for your patient listening.
Hello. Which was efficacy and safety of darolutamide plus ADT in patients with metastatic HSPC from the phase 3 ARA-NOTE trial. Dr. Aditya? Dr. Aditya,
Gitika can share the.
yeah,
Gitika,
please.
can you share the slides? Yeah. And obviously, big thanks to Dr. Rajat, who has been my guiding force in treating my patients, and he is always there to help you and guide you. And again, thank you very much for having me on this platform. And I'll be talking about the phase 3 ARA-NOTE trial. So yeah, next slide. So trial revolves around the discussion of darolutamide. So from ARA-SENS, we are shifting gears to ARA-NOTE. So eligible patients that had MHS-PC by conventional imaging and ECOG normal and ADT less than 12 weeks. Patients were randomized into 2:1 to darolutamide daily versus placebo, each with the ADT. And the primary endpoint being the radiological survival and the secondary endpoint being the OS. Also, along with it was time to initiation of anti-cancer therapy, time to CRPC, time to progression, time to pain and safety. So I think with the trial design, you can pretty much, get the gist that there were 670 odd patients were MHS-PC patients with good ECOG status, and were randomized into 2:1, darolutamide plus ADT versus placebo plus ATD, and then obviously the primary being the RPFS. So next slide. So if we were to see the group, I think you can just see the maximum age in both the groups is to the tunes of 93 years or 91 years, which is again an astounding because these drugs can be given in that subgroup as well. And if we were to see the race-wise, I think it is all well matched along with the ECOG status, 52% being ECOG 0 and 1 and 2 again being 47%. I think there was a slight higher number of patients that were ECOG 1 and 2 in the placebo arm. But having said that, what about the visceral disease? If we were to see to the tunes of 20% in the darolutamide arm and 12% in the placebo versus no visceral disease in 90%. And coming on to the disease volume, I think the volume being high in 70%, and again, this was also well matched. So you can just get a brief idea how are these patients, distributed along both the arms. And the median age here was 70 years, 31% were Asian, 9.7% were Black, and the PSA at the baseline was 21. And we were to see the primary data cutoff at this June 7, 2024. Daro with ADT significantly improved the radiological PFS versus the placebo, and it has reduced the risk of radiological progression or death by 46%, which is fantastic. So can I have the next slide? Yeah. So if we were to see the forest plot, and this drug is helping across all the patients, including the high and the low volume HSPC, along with the patients who are having, visceral mets. So you can just see how darolutamide has improved. I think with the ARA-SENS, we are more comfortable in using the triplet kind of a regime. And now this was a doublet. If we were just come and look at this point, which shows the visceral mets. So patients who are having visceral mets, somehow they are not deriving that much of benefit. If patients are not having visceral mets, the combination of darolutamide with ADT is quite helpful and it favors. So that was something to keep in, that is something to keep in mind. Next slide. So darolutamide was associated with the positive trend of OS, and the clinical benefit was seen across all the secondary efficacy endpoints, including the time to CRPC and time to pain progression. And you can see the hazards. It is to the tunes of zero point 0.4 in the time to MCRPC, and graphs are separating well on early, somewhere around 6 months or odd. And if we were to see time to pain progression, again, it is helping over there with the median of 29.9, and I think median was still not reaching the time to pain progression. So next slide. Additionally, there was a benefit favoring Darrow with ADT for time to subsequent therapy and time to PSA progression. If we were to see, 69% of the patients did derive benefit in terms of Darrow with the ADT. Next slide. And further, PSA less than zero point 0.2 at any time during the treatment occurred in 62.6% of patients of Darrow with ADT compared to only 18.5%. So you can have deeper response rates, you have good control, and you have fast PSA declining trend as well. Next slide. So just to give you a full summary of the secondary outcomes in the highlighted form, I think you can just see. So OS benefit, I think it's still not reached. They still need few years. Time to MCRPC, you can see it. The combination of Darrow with ADT is quite helpful over there with hazards of 0.4. Then time to PSA progression is also nice. It is hazards of 0.3. And time to initiation of subsequent systemic therapy for prostate cancer hazards of 0.4. So overall, if we were to see, I think if you choose your patient well, I think this combination of Darrow with ADT in such population will help us. Next slide. And the incidence of treatment emergent adverse events were quite low and similar between both the groups. And if we were to see the treatment discontinuation due to any adverse event, you can see it is still lower in Darrow with ADT as compared to the placebo with ADT. So obviously there is no new safety signal to be seen here. And in fact, this combination is pretty much safe. Next slide. The following table shows that the treatment emergent adverse event associated with the AR androgen inhibitors were generally similar between the groups. The fatigue was less common in the darolutamide ADT group versus the placebo group, and I think rest of them were all well matched. And we all know how ADT and these AR inhibitors can have asthenia or hormonal imbalances, and one of the most critical point is to know about their bone health or bone fractures. So I think we have to be on lookout, and getting a lipid profile done also helps you a long way, because some of the patients, they do land up with after 2 or 3 years some with a cardiac event. So you need to be on a lookout for lipid profile along with the diabetes and hyperglycemia management. Next slide. So just to give you the summary, Darrow with ADT significantly improved the radiographic PFS. It has showed benefit across all the secondary endpoint. And the only hitch over here is that it has not shown a significant benefit over the patients with the visceral mets. So that is where I'll be reluctant to use it. And Darrow had a favorable safety profile based on these results of Arrow Not. And Darrow plus ADT without DOSI should become an additional standard of care in MHSPC. Next slide. Yeah. Thank you. Back to organizers.
Yeah, thank you, Dr. Aditya. So, next time when the patient comes to you, so there are options of darolutamide, enzalutamide, Abiratron is there, apalutamide is there. In metastatic HSPC, if you want to not go for a triplet, these are all the doublets that you have. So,
Right.
how would you really choose? This
So
for
I think
me is
one
a
is the cost.
little
So let's
perplexing
start
here,
how we yeah.
because here we see that there is a high burden group also which is benefiting, and that the visceral disease patients did not benefit as much. So this
Exactly.
is a little dichotomy here. And of course,
Yeah.
cost being aside, I mean, there is any other way you would like to really choose
No.
these
I
two?
think if the patient is coming to me in my practice, for me the foremost is the cost, and if obviously there is no hitch in the cost, then all the options are on table, because this is a very costly drug, and followed by that you need to know about the comorbidities. If you have any potential seizure related, obviously I will not be able to use, ANZA. If you have any cardiac morbidity, let us rule out abiraterone. And I think apalutamide is one of those safest one, and darolutamide, where you can use with in a patient who do have a huge amount of comorbidities and having no much side effect profile over there. But I think taking a good history, knowing how the patient will benefit, and knowing your select subgroup, that will help you in taking the call. There is no one single answer, because you have rightly said you have 5 6 options. So you have to know that comorbidity list and the cost. Only then you will be able to, because all the drugs, they are doing fantastic in combination with ADT.
Yeah. Yeah, that is right. I think almost all of them have shown a PFS which is to the tune of about 18 to 20 months. Apalutamide also has got cardiovascular side effects, so that has to be kept in mind. I think out of the side effect profile, darolutamide is probably the best acceptable in terms of the comorbidities. But then there is a little dichotomy for Aranaut because of the visceral disease and the high volume disease, both of them being together. And I think they would have to explain this more in the full set that they would
So they
present.
must be having those patients now, where skeletal burden is more, but visceral
Yes.
disease,
Yes.
burden is not there. So that is the only way you can have patients do good on darolutamide.
Yeah. Agree. Right. Thank you so much for
Yeah.
presenting this in a very nice way. And we move ahead and talk about the next abstract which was presented. And this is going to be talked about by Dr. Nitish Garg, who's a consultant medical oncologist at Mohali. He's going to talk about radium 223 and enzalutamide in asymptomatic or mildly symptomatic patients with bone metastasis in CRPC patients, the first results of Peace 3 study. Dr. Nitish, over to you.
Thank you, Dr. Rajat, for inviting me to have this presentation. And definitely, uh, this presentations about GU and GIA has been changing, and these trials, the newer abstract, we somehow have to incorporate in our practice and learn more about these. So this trial, which I'll be talking about, is Peace 3. So we have been reading about Peace 1, Peace 2, and now it is Peace 3, where radium has been used in metastatic CRPC patients along with enzalutamide. But again, thing to keep in mind, these patients are either asymptomatic or mildly symptomatic.
Sir, requesting you to make the full screen.
That is in full screen, is it not?
No, sir.
Just a minute. Now,
Sir, click on play button.
yeah, is it now?
No, sir. Dhruv, can we
Yeah,
upload from your side?
yeah, I'll just share with my from my side.
Okay. So in the meantime, so a little background about the metastatic CRPC setting. When we know that a patient is having metastatic castration-resistant prostate malignancy, so we always evaluate with the testosterone levels either in a post-orchidectomy setting or post androgen deprivation therapy, which is usually by either Relugolix, or you can say GnRH analogs or antagonists. So just keep moving the slide slowly. I'll be very quick with it. Okay, so abiraterone and enzalutamide we know are the standard of care in the first line treatment for metastatic CRPC setting along with ADT. And it has been a challenge because when the patients progress, the patients usually progress in the bones. And one or the other site of the bones can be addressed with a local RT, but if there are multiple sites involved, we don't know how to help them. So initially it was strontium, then radium, but now it has been used in a combination with enzalutamide. So this trial talks about that. So radium 23 223 is an alpha emitting calcium mimetic that selectively targets the bone and induces a double strand DNA breaks. So because of that, there is increased chance of increased cancer killing. So this was also seen previously in the Simca trial, where the patients who have not been yeah, I mean, who have where we have not used the newer ADTs that time, abiraterone or enzalutamide, post docetaxel had bone disease. So in those patients, there was a improved overall survival with a progression, the relative risk of death reduction by 30%. So from there, the extrapolating that data, it was the ERA 223 trial where abiraterone was added to the radium 223, but unfortunately it did not show a great benefit, and also there was some increased risk of fractures, probably maybe because of abiraterone is used in combination with steroids, and those steroids caused osteopenia in an increased way. Next slide. So, this phase 3 is a prospective phase 3 trial for the metastatic CRPC patients with bone metastasis, again, who are asymptomatic or mildly symptomatic. So, the eligible patients are no prior enzalutamide or radium 223, or no known visceral metastasis to be seen. No the prior treatment with abiraterone and docetaxel in the hormone sensitive setting was permissible, not in the metastatic CRPC setting. So the randomization was, the study participants went 1:1 randomization, where experimental arm had radium, which was given every 4 weekly for 6 cycles, along with enzalutamide, and the enzalutamide in the control arm as a full dose. Next slide, please. So the primary endpoint was radiographic progression-free survival, or PFS, and the secondary endpoints were safety, the overall survival, time to next treatment, time to pain progression or symptomatic progression, and time to first symptomatic skeletal event. Next slide, please. So this trial, it had a total of 446 patients, which were randomized to 1:1, and 223 patients in the each arm. And main thing here to look at is, after the involvement of 120 patients, approximately, the use of bone protecting agents like denosumab or zoledronic acid bisphosphonates was allowed. Next slide, please. So when we look at the baseline characteristics of these 446 patients, they're fairly well matched. The median age is 70. PSA median is 25 to 26, and the performance status of these patients is mostly 0. And if we look at the prior treatment, docetaxel was used approximately in 67% of the patients, and abiraterone has been used in 4 to 7% of the patient. So there was a differentiation based on number of bony metastasis, less than 10, more than 10, equal to 10, or missing or diffuse lesions. So again, fairly well matched status there. Next slide, please. So when we look at the patients who had completed treatment, overall 88% of these patients were able to treat 6 cycles of radium along with enzalutamide, and only 11%, 11.6 patients were not able to control. So this tells us that indirectly that the safety profile or the side effect profile was fairly well tolerated, and there were no great issues with the tolerance. Next slide, please. So when we look at the primary endpoint, there was significant improvement in the radiographic progression-free survival. And if we look at the delta in the months, it was 3 months with the addition of radium, and which reduced the relative risk by 31% of progression, radiographic progression. And the 2-year radiographic progression-free survival, 24-month radiographic progression-free survival showed that 45% of the patients were alive, or sorry, they were radiographic progression free versus 36% in the control arm. So a 9% improvement is still a significant improvement in these castration resistant patients. So, next slide. So again, the forest plot showing the same, that most of the patients who, whatever, if it was less than 10, more than 10 bone lesions, whatever may be the age, the performance status, almost all the areas addition of radium helped. So there was no significant bad safety signals which were seen with the addition of radium. Next slide, please. So the overall interim analysis, uh, which was actually done at 80% of the overall events and has been planned to be done at end of the completion of trial, because there was a slight overlap of or crossover of the enzalutamide versus the enzalutamide plus radium arm. So when we look at the improvement, the delta was to the tune of 7 months. So this, because of this overlap and the crossover with the improvement, it has been planned that the trial has to continue at end of the full analysis. We will still have the results, and that may give us a better idea that is it going to be effective or not. Next slide. So there is significant improvement in the time to next systemic treatment. So the hazards or relative risk of increase in the time to next treatment was reduced from 51% in the only enzalutamide arm to 30%. So 30%, 21% less patients needed the next treatment early at 2 years. Next slide. Again, the symptomatic events. So the skeletal symptomatic events were almost the same in both the arms. It was at 24 months, 18% of the patient in each arm had the similar benefit. So there was no significant benefit in this group, but yes, the time to next systemic treatment was actually delayed in the ANZA plus radium. Next slide. So as I discussed, no new safety signals, but yes, there was grade 3 to grade 5 side effects, which increased from 19 to 28%, and the combination of percentage deaths increased by 1% from 2 to 3%. But specifically, if you talk about the drug-related side effects, they were not there. They were not seen. So no significant increase in the toxicities. But yes, there was slight increase in the side effects. Next slide. And the main side effects were hypertension, fatigue, and next slide. Hypertension, fatigue, fracture, anemia, and neutropenia. And anemia and neutropenia, we definitely know it is probably because of the bone marrow suppression due to the radium. And possibly that might have led to a few increased side effects, but as such, they were not documented. Are these because of the drugs or not? Next slide, please. So in summary, when I talk about enzalutamide plus radium 223, I feel that this trial has given us a significant improvement in the radiographic PFS with reduction in the relative risk of 31%. And this improved RPFS has improved the overall survival also. So looking at that, it has increased there was a significant improvement in the time to next systemic treatment. With this result, the combination of enzalutamide plus radium plus a bone protecting agent has a potential new first line treatment in the metastatic CRPC arm for those patients who have asymptomatic or mildly symptomatic bone metastasis and who have not received a prior androgen receptor pathway inhibitor in the metastatic CRPC setting. Thank you.
Thank you, Dr. Nitish. I think very well presented, and this can certainly be one of the options going ahead. Important caveat you very rightly described is that patient has to be mildly symptomatic, and it should only be bone metastasis which should be there.
Yes.
Interesting to see that the previous trial with the Biratron actually was a failure, but this trial is positive. But then, of course, all trials come up with their different inclusion criteria, and we have to take it as it actually is presented and concluded. Thank you so much.
Thank you.
So, uh, After this abstract, we have Dr. Varun Goyal. He's a senior consultant in the Department of Medical Oncology at Rajiv Gandhi Cancer Hospital. He's going to speak about the efficacy of lutetium therapy in PSMA positive metastatic CRPC patients following progression on androgen receptor pathway inhibitor, the SPLASH study. Sir, are you there?
Yes, I'm here.
Hi,
Hi,
sir,
Rajat.
please.
So, thank you for this opportunity. And as I already told that I'm going to discuss about the role of lutetium therapy in metastatic CRPC patient. So, please share slide from their side. Study name is SPLASH, and this is efficacy of this lutetium PNT 2002. This is a radionucleotide which is bound to PSMA and PSA, and then these PSMA positive patients with metastatic CRPC. This whether this regime is efficacious or not. So this trial is about that. Next slide. So this 177 lutetium, it is a prostate-specific membrane antigen targeted small molecule radioligand. It is linked to DOTA GA radiometal chelator. This SPLASH, it is a phase 3 randomized study which is designed to evaluate efficacy and safety of lutetium therapy in these metastatic CRPC patients. Already have been progressed on androgen receptor therapy. So this delivers PSMA targeted radiation to prostate cancer cells directly, causing DNA damage and ultimately cancer cell death without much systemic side effects. Next slide. So this is the study design. So in this trial, investigator had included patients who had already progressed on prior treatment with at least one either abiraterone or enzalutamide or similar drugs. So all patients to be included were required to have PSMA avidity in the PET scan, in PSMA scan. Taxane chemotherapy for castration-sensitive disease is allowed, but not for CRPC setting. And at least more than 1 year to the taxane therapy, like treatment-free interval for the taxane should be there. Eligible patients were randomized to 2:1 ratio, and trial arm were given lutetium therapy 6.8 GBQ plus minus 10% every 8 weekly for up to 4 cycles, and control arm is another alternate androgen receptor therapy. If patient already progressed on abiraterone, then anizutamide, otherwise vice versa. So experimental arm was given this trial. Both the arms were given this treatment till radiographical progression, and crossover is allowed if patient further progress on enzalutamide or abiraterone, then those patients may be given lutetium therapy. Endpoint for this study were taken. First point is radiographical progression, otherwise PFS, OS, overall response rate, time to skeletal event, PSA 50 response, quality of life issues, and safety profile. Next slide. So this is the statistical analysis plan. First endpoint was radiographical PFS by independent committee using RECIST 1.1 for the soft tissue lesions. And key second endpoint was OS. It is time from randomization to death for any cause. Second endpoint, as I already stated, overall response rate, duration response, time to first skeletal event, PSA response rate, and quality of life and safety profile. Next slide. So a total of 412 patients were eligible and have been randomized if in either of the experimental versus control arm. 85% patient in control arm of the alternate androgen receptor therapy were crossed over to the experimental treatment at the radiographical progression. So this is significant that almost every patient have received nutrition therapy, and trial control arm patients, most of the patients, 85% patients were given nutrition therapy after the progression. Next slide. So baseline patient characteristics we can see in this slide. So median patient age was 72 years, and median PSA, although was lower in experimental arm, it was 13.2 versus 19 nanogram per ml. 17% of the patient had received prior taxane, but those should be at least 1 year prior, and that is setting is CSPC. Most patients had received prior androgen receptor therapy for M1 status. So that was in the inclusion criteria itself. So otherwise, both the arms are well matched to each other. So although numbers are slightly less, but still for this setting, it is significant number of patients, and both the arms are so good randomized trial. Next slide. So at the data cutoff date of November 1st, 2023, with a median follow-up of 12 months, this trial met its primary endpoint of radiographical progression-free survival benefit with the lutetium therapy. And numerically, it is 9.5 months with the lutetium therapy versus 6 months with the alternate this either abiraterone or ezetimibe. So by the look of it, we can say that obviously are more than 50% improvement. P-value is statistically significant. Hazard ratio is 0.71. Both the in this Kaplan-Meier plot, both the lines are well distant to each other, and this separation start from the maybe third or fourth month, and there is no crossing over later till the follow-up of median follow-up of 12 months, and even later then. Next slide. And if we see this radiographical progression according to subgroup analysis, so even then, this benefit have been seen in almost every subgroup, whether it is prior use of bone health agents is there or not, whether measurable disease at baseline or not, whether it is European patient or not, white versus African versus Asian, whether PSA is less or not. So in every subgroup, this nutrition therapy have shown response in the term of radiographical progress. Next slide. A complete response was observed in 9.3% patient in experimental arm. So clinically, and we all know that in our clinics, it is almost unheard of. If a patient of CRPC already progressed on one of the ARPI, then with another agent, another treatment schedule, if they even 10% patient can go to CR, so that is clinically very relevant. So best overall response was observed in 38% patient versus 12% patient. If we compare lutetium therapy versus this ARPI therapy, here in this regards also p-value is statistically significant. Median duration response was 9.4 versus 7.3 months respectively. Next slide. So another parameter which have been evaluated in this study is PSA 50 response. So it was observed in 36% patient with lutetium therapy versus 15% only with the alternate ARPI therapy. Biochemical progression-free survival also favored lutetium therapy. Next slide. Coming to quality of life issues. So health-related quality of life deterioration, which have been assessed by FACT-P questionnaire, it also favored lutetium therapy. Time to opioid consumption similarly favored the lutetium therapy. Obviously, more number of patients are showing response, so more number of patients are getting better, so quality of life improving, and even opioid use decreasing. Next slide with the lutetium therapy. So the first interim analysis of overall survival, although did not demonstrate an overall survival benefit, and that may be because of the fact that after progression, most of the patient, around 85% patient, had crossed over to the lutetium therapy. So all the patient have received lutetium therapy also. So maybe this is the reason there is no overall survival benefit have been achieved in this study. So maybe with the further follow-up analysis, we will get to know if there are any. Next slide. So overlapping overall survival Kaplan-Meier curve suggests potential violation of the common treatment effect. Assumption in the rank preserving structural failure time model method. So due to the observed violation in the assumption of this model, other known pre-specified preliminary method to adjust the crossover were employed. And then it has shown that there is overall survival hazard ratio of less than 1. Next slide. Coming to side effect. So we have shown you that in this study that responses are better, survival is better, at least PFS is better. Overall survival numerically is not better, but still. What about side effect? So any grade treatment emergent adverse events were observed in nearly all patients. So, but overall adverse event profile also favoring lutein therapy. Grade 3 or more events were observed in only 10% patient in the experimental arm and 12% patient in the control arm. There is no treatment-related adverse event which lead to death. The treatment emergent adverse event leading to treatment discontinuation was observed only in the 2% patient in the lutein therapy and 6% patient in the ARPI therapy. So very like a few patient in which treatment has to be discontinued because of the side effects, and most of the patient have continued the treatment. And if side effects are there, most of them are grade 1 or 2, manageable and reversible. Next slide. Grade 3 or more anemia were more common in nutrition therapy. Arthralgia and fatigue were more common in the ARPI therapy. Other side effect, if I will enumerate, like fatigue, dry mouth, nausea, arthralgia, back pain, constipation, all that type of side effect were there, but most of them are of grade 1 or 2. Grade 3, 4 side effect in we can see here are very less in number, maybe less than 1% or around 1% only. Next slide. So to summarize, this lutein therapy reduced the risk of radiographic progression or death by 29% if we compare this with the another alternate ARPI, and that may be biratrone followed by enzalutamide or enzalutamide followed by abiratrone. Overall survival data continue to mature. Till now, till around median follow-up of 1 year, overall survival benefit is not there. And that may be because of the crossing over of the active treatment after progression of the control arm. Multiple secondary endpoint favoring nutrition therapy, which include objective response rate, PSA outcome, health-related quality of life. And this nutrition therapy safety profile also is comparable to the ARPI control. Most of the time, side effects are well manageable and reversible. Next slide. Thank you. Over to the organization.
Thank you, sir. So I think what this data set tells us is that when you have used one newer anti-hormonal therapy, instead of going to the other one, there should be use of lutetium therapy. And it is very clear that it has got a benefit in terms of radiographic progression-free survival. Also, I think I can draw parallels with another trial which came in NEJM in 2019, which was the CARD study, which talked about the use of cabazitaxel after one ARPI before we go on to another ARPI. And there they said that specifically if that ARPI has been used within the last 12 months. So I think it is very clear that from one oral drug to another oral drug, if we can sandwich something else, be it lutetium therapy or cabazitaxel, presuming that docetaxel has been used, there is an improvement in PFS. The CARD study did show an OS benefit as well, but here the OS benefit has still not come. So I think it is practice changing, sir. What do you think?
Yes, in our clinics, we have seen very frequently, if patient progress on one type of this hormonal treatment, if we give another tablet, most of the time PFS is very less, and most of the time patient progress very fast. So this lutein therapy, it is coming in big way, because this is very well tolerable. Most of the time patient shows response, and we buy time. And as you told, we need some gap in between these two drugs, and then on progression on that we can again give another ARPI. So this lutein therapy initially in our practice, maybe we have started given this as a desperate measure in the last maybe post multiple line, even after dosing Kabaji. But nowadays, uh, a a vast literature have come that it should be maybe just after first line, or maybe in the upfront setting we can use in the CRPC patients with good results.
Yeah, thank you so much, Dr. Varun. For the
Hello.
next, yeah.
Yeah, sorry, I didn't realize that I'm on mute. So, after this, we are going to discuss the treatment options for metastatic urothelial cancers. And with us, for to discuss that, we have with us Dr. Denny Gupta, sir, who's a senior consultant in the Department of Medical Oncology at Dharamshila Narayana Super Specialty Hospital in Delhi. Sir is there, Dr. Denny?
Yeah, Rajat, I'm here.
Sir, good afternoon. Please take it
Yeah,
forward.
good afternoon. Yeah, sure. I think my slides will be visible, no?
Sir.
Sorry?
Yes, sir, it is visible.
Oh, it's visible. Right. Thank you. So, good morning, everyone, and many thanks to Dr. Rajat and other organizers for calling me here. So today, now after prostate, we are going to discuss urothelial cancer, metastatic urothelial, and what are the right way to maintain the continued response with the first line of the chemotherapy itself. So, we all know that once we give chemotherapy, we do get response, sometimes in the form of partial response or stable disease, and quite oftenly, not quite oftenly, complete response also. So we know chemotherapy decreases the tumor burden to achieve disease control and increases the immunogenicity of the tumor microenvironment. And thereby, if we use immunotherapy afterwards, so maybe say we can say avelumab, it is more effective in patients with these type of tumor which are having reduced tumor burden and high mutational burden, like this urothelial carcinoma. So both these combining together causes the enhanced clinical efficacy with this sort of maintenance therapy. Because we all have observed that once we give first line GemCis or Gem Carbo, so a lot of study have also shown the similar type of result that we do get response rate near about 80 to 90%. This blue bar is showing the complete response as well as partial response, and green one are the stable disease. So this is a mixture of all these three types of response and taking together 80 to 90% with the first line chemotherapy. So and we do observe that these type of patient progress in due course of time over a period of 1 to 2 year at metastatic sites or local recurrence. So there is a Javelin Bladder 100, which I'm going to discuss today. It was phase 3 randomized open label study, and inclusion criteria were unresectable, locally advanced or metastatic UC with miserable or stage 4 disease. And these patients must have received standard first line chemotherapy, which is GemCis or Gem Carbo as a induction chemotherapy, and either 4 to 6 cycles were allowed. And then there was a treatment-free interval of 4 to 10 weeks with radiological assessment to get the correct response of the chemotherapy. So, say patient may have CR, PR, or stable disease, although progressive, they were excluded. So these type of patients were included: CR, PR, or stable disease. Good 700 patients were included. 51% were PDL1 positive, so there was stratification, PDL1 positive or negative. And another stratification was best response to first line induction chemo, CR, PR, or stable disease. Another stratification was metastatic sites, visceral versus non-visceral. So after achieving this some type of response, at a gap of 4 to 10 weeks, they were put on maintenance with the avelumab, which was standard doses 10 milligram per kilogram, 2 weekly interval, along with best supportive care in roughly 350 patients, 50% of the patients. Until progressive disease, they were continued on avelumab or unacceptable toxicity or withdrawal. So second control arm was only best supportive care. So endpoints, primary endpoint OS, overall survival, and subgroup analysis they have done on PDL1 population. And the secondary endpoint were PFS or response rate, time to response duration, safety and tolerability and all. So first, which was the primary analysis, that was overall survival. So median overall survival we have seen in this particular trial, it was 13 months. To be precise, 29.7 months with avelumab. Vis-a-vis 20 months alone with the best supportive care only. So there is a around 9 to 10 months improvement in median overall survival with a hazard ratio of 0.77, thereby causing 23% reduction in the risk of death. So that was the OS advantage. And if we talk about PFS, progressive-free survival, with the avelumab, we have seen in this 5.5 months as compared to 2.1 months only with the best supportive. So 3 months advantage with hazard ratio of 0.54. So we can see the curve. This is clearly separated apart, even in PFS as well as oral survival. Then there was a question that whether this particular regime of maintenance it can be tailored to our practical consideration, whether patient have achieved received some different platinum partner or duration of this therapy 4 or 6 cycle, or what was the response or treatment free interval length. So they have seen in this trial for all these variation, uh, whether it was gem carbo, response rate was equivalent, or duration of cycle of this chemotherapy, first line, 4 cycle or 6 cycle, hardly make difference after this maintenance, or response also, irrespective of maintenance, also response was seen, and treatment-free interval length also did not make any difference in the outcome with this maintenance. Then there was the important subgroup analysis of Asian subgroup. So out of these 700 patients in Javelin 100, 147 patients were Asian subgroup, in which 50% roughly 1:1 randomization as the original protocol. Avelumab was given along with best supportive care until progressive disease or unexpected toxicity. Endpoint was similar. So Asian subgroup population contributed around 21% of the overall population. And if you see the median overall survival benefit in these subtype of Asian population, we can see at 2 year, they again touch the 28.7 months, again touch the that magic number of 30 months, which was seen in the overall population. So 60% was the response rate, and overall survival, we can see it is matching up to the overall population. And if we see the PFS also was 3 times higher with the avelumab. Then there arises a question for how long we can continue the avelumab, because in the original protocol, in the original study, they mentioned that this needs to be continued for just a minute. Hello, बाद में कर लेना. So how long we should continue the avelumab? So there was segregation, like for how long patient were exposed to avelumab. On the right side, we can see roughly 47% patient were exposed to avelumab for more than 6 month duration, and 28% for more than 12 months, and 20% for more than 2 years. So if you see the outcome separately, they've shown this 26.7 months median PFS, right? Median PFS in those patients who have been given for more than 12 months. And median OS was not reached, I think, till the time of this publication. So corollary from this slide, we can take that minimum, at least we should advise for 1 year to get the maximum, optimum result with this avelumab maintenance. So another atypical type of outcome they have observed that if we give, say, for example, we give avelumab for 1 year or 2 year as a maintenance, so more than 90% probability of additional 1 year over survival benefit. Additional over survival beyond 1 year is how much? That they have shown 33.7% OS benefit. And if we go beyond 2 years, then the additional 1 year OS is 19.4%. So it does make difference if we give for longer duration of avelumab, and then no new safety concern was identified if we give longer duration of avelumab, and patient experiencing any treatment related adverse event for more than 1 year was 50%, for more than 2 years was 35.5%. We'll come to the adverse event. And this survival outcome which we have just discussed, say median progression-free survival, median OS, PFS was 5.5, and overall survival was roughly 70%, 12 months. So it is more or less matching with all other real-world study also. What they have seen, there are so many studies in different countries, Indian, US, France, Italy, US and European country. So more or less every study have shown the similar type of result. The green, this circle we can see in the last 5 o'clock position. So they are showing 82% 12 months overall survival in the Indian real world study. In fact, it is showing better results than Javelin Bladder 100. So this was a percentage at 12 months over survival, median progression-free survival, and now they're saying that median also from the start of Avulumab, it was 23.8 months, and OS was 29.70. Again, same 30 months number, and in most of the real world study also it is touching the almost 30.5 and so. So these were the results in real world study and all across the various parts of the world. So now adverse event. So this adverse event, this green bar, we can see that any grade side effect, and red one is the more than or equal to 3, grade 3 side effects. So pruritus was the most common. It is being seen in these population, and 13.7% pruritus, and only 0.3% was the grade 3, more than grade 3. So very minimal. More than grade 3 adverse event, if we see, it was seen in some 0.9% infusion-related reaction, and 2% was amylase increase, and 3% was lipase increase. So we can monitor these pancreatic enzyme in follow-up of these patients who are on Avulumab maintenance. Less commonly side effect, well tolerable, are fatigue, asthenia, diarrhea, arthralgia, pyrexia, hyperthyroidism, and all that. These were there, but I think well managed. So, so we have given Avulumab maintenance. What about after these patient progresses? So then the discussion point arises: what is the best sequence of treatment, whatever we have with us? First line chemotherapy we give, and then patient achieves some response. Avulumab maintenance we have given, and 30 months is the median overall survival. And after this patient progresses, then we initiate on the second line chemotherapy, which is based on the physician discretion. Some are in favor of paclitaxel, some give some immune checkpoint inhibitor, or so on. So with this sequence, I think if we see the further demarcation of Javelin bladder study of 100 in the this basal supportive care arm, most patients who received subsequent therapy received a PDL1 or PDL1 inhibitor. We see the first line therapy, including first line maintenance. Avulumab, we can see this blue one. They were still on first line. And on supportive care, they have gone to the PDL1 or FGFR inhibitor. And in the Avulumab arm also, few patients are going to the in the second line with the checkpoint inhibitor and FGFR inhibitor based on the molecular marker analysis. So, summary of this treatment sequencing, in particular in this particular trial, 350 odd patients were on Avulumab arm, 43 are still receiving Avulumab, and rest of the patient have discontinued Avulumab, maybe for progression or intolerability. And no second line treatment were reported in 122 patients, although 185 did receive the second line treatment. Out of this, 11 patients were on PDL1, so immune checkpoint inhibitor, and 75 were rechallenged with platinum, and other anti-cancer treatment was given in roughly 100 patients. So all these type of chemotherapy, or including EV and including this adafitinib, this new drug which is coming up for FGFR3 as an inhibitor. So maintenance Avulumab in real world study was consistent with the even in India, consistent with the previously reported clinical studies. So this was the conclusion of this multi-centric Indian real world data, which confirms that Avulumab maintenance treatment efficacy data is consistent with the previous published studies. So all survival here was also seen in 82% patients at 1 year timeline. So correct sequencing of available agent leads to unprecedented median of survival of 40 plus months. First line platinum, response, maintenance, Avulumab. Second line EV, if we can give, so median of survival we can achieve up to 40 plus months with this sequence. And evidence study is there to support that. Eurocase study, I think full detail is not available. So to summarize, this best sequencing we can see is with the avelumab maintenance. We give antibody drug conjugate in the second line, and then later on some other line, 40.8 months. EV 3.302 as upfront with the Pembro. This combination is also coming up, and with this we have 31.5 months. Platinum-based avelumab maintenance, then survival after maintenance is 30 months. We have discussed, and JB again 130 months, and cisplatin eligible CM901 Nivo GC and 21%. So out of all these things, combination of first in which ADC have been used after this avelumab maintenance have shown the best total outcome. To summarize, up to 90% of patients are eligible for maintenance. First line avelumab maintenance leads to median overall survival of 30 months, superior overall survival regardless of prior platinum-based chemo regime, duration of regime, or response to treatment of this chemo or treatment-free interval. So, irrespective of all these things, better overall survival was achieved. Robust real-world evidence data is consistent with the efficacy and safety. 80% of patients are eligible for second-line treatment after avelumab maintenance. Unprecedented median overall survival of 40 plus months with the sequence of first line avelumab maintenance followed by second line EV was achieved. Thank you. Any question, I'm happy to answer and get back to organizer.
Okay, thank you so much, Dr. Denisa, for the
Yeah.
wonderful presentation. And moving ahead for the next session. And session is a breast cancer. We can discuss about that. And this session is sponsored by AstraZeneca. And I would like to invite Dr. Ankit Batra, sir. He's an assistant professor medical oncology, CRIHIMS, Dehradun. So it's over to you, sir.
Hi, good afternoon. Can anyone share my slides? Yeah, by the time slides are being put up, thank you, Dr. Bajaj, for organizing this event and AstraZeneca for having me here. So I'll be speaking about the role of trastuzumab deruxtecan for the treatment of HER2 low in metastatic breast cancers. This would be the overview mainly based upon the Destiny Breast 04 trial. I'll be discussing the intricacies of these trials. Next slide, please. Next slide. So the introduction to the metastatic breast cancer and especially the HER2 low is a new term. We have been talking about this term for the last 1 or 2 years. Breast cancer, we all know that it's the most common form of cancer worldwide, and around 25% 5-year OS is seen for metastatic breast cancers. But still, it's a significant burden on the society in terms of mortality, in terms of challenges, in terms of the toxicities and the lines of treatment patient has to undergo. So still a lot of unmet need is required in this arena. Next slide, please. So we all know that the HER2 expression, the previous classifications of the HER2 was quite simple, that either by ISC it is 3 plus, or if it is ISC 2 plus and then the fish is positive, then we'll call it as a HER2 positive. Otherwise, in all the other categories, it is HER2 negative. So these were clearly HER2 negative and positive in the previous classification. Next slide, please. And this was the treatment paradigm in the first line, second line, third line for these categories, be it hormone receptor positive or negative. And we can see the timelines and the median PFS with all the treatments available. So if we talk about the HR positive, HER2 negative MBCs, there is almost a 50% drop off in the median PFS after the endocrine therapies are exhausted. So after these endocrine therapies are being used, and the CDK4/6 inhibitors are used, we are not left with much of the options. And with the second line and the third line therapies, the PFS is very minimal. So again, a very challenging situations in these kind of settings, and we need something else to treat these patients. So we need there is an evolution of the HER2 classifications, and we came to the HER2 low and ultra low. Next slide, please. And talk about that how we use this classification in the treatment of the patients, how they can be benefited. So when we talk about HER2, these new classifications, we know that previously there was HER2 positive, which constitutes around 15 to 20% of the patients, and the ISC 0 score, which constitute around 1/3 of the patients. What about those which were ISC 1 plus or ISC 2 plus and FISH negative? So these are the class of patients where we think that something can be offered, and then these new terms has been devised, that is the HER2 low. So next slide please. So this is almost around 50 to 60% of the patients falling into this category, and this is the area of research where I think something can be done beyond ET therapies or the CDK therapies, which when exhausted and the patient is not left with anything else apart from physician choice chemotherapy. So here comes the Destiny Breast 04 trial, which has included these category of patients and used trastuzumab deruxtecan as a target in the second line metastatic breast cancers and had shown survival benefits. Next slide, please. So HER2, what I told in the previous slide, is similarly depicted in this cartoon, and around 50% of the patients falls into this category of HER2 low, and this can be targeted to increase the response rates and the survivals. Next slide, please. So, since Destiny Breast 04 NR2 has become the first category 1 NCCN preferred treatment for HER2 low metastatic breast cancers, we can clearly see that it has become into the guidelines and it is now category 1. The dosage we all know, 5.4 milligram per kg IV day 1, and it is given every 21 cycle. Next slide, please. Coming on to the mechanism of action, we all know that NR2 is an engineered HER2-directed antibody drug conjugate. It has three components. One is the potent topoisomerase 1 inhibitor payload and a tumor-selective cleavable linker, which combines with the HER2-directed ADC. And that is the beauty of this, that helps into the on-target and the killing of the cells and the nearby cells. So next slide, please. So these are the details, how it is formed. The target is HER2, the antibody, we know that it is trastuzumab, and the payload, which is exatecan derivative, that is the topoisomerase 1 inhibitors. The important difference to note that the drug to antibody ratio is 8:1, and the tumor selective cleavable linker is there, which is not there in the previous versions of the ADCs. And that's why the anti-tumor bystander effect is also significantly increased because of that. Next slide, please. So this is the mechanism. Once after the trastuzumab deruxtecan binds to the HER2 found on the malignant cells on the surface, it is internalized, and a linker which is there, which is cleavable because of the actions of the lysosome enzymes present in that tumor microenvironment, get released through that cleavable linker, and the DXD causes the targeted DNA damage and apoptosis in the cells, leading to the cell death. It also has the ability to cross the cell membranes, because of which the bystander effect on the nearby cells is increased. So even if the HER2 positive or the HER2 low cells are there, and we know that the tumor is heterogeneous, and some cells are not HER2 enriched or positive, so that cells also get killed because of this bystander effects. Next slide, please. Next. This all I have explained. You can move on to the next slide. So we'll come on to the breast 04 study design. It's a phase 3 open label multi-center randomized control trial, and HER2 low patients with unresectable or 1 to 2 prior lines of chemotherapy in the metastatic settings have been received. The HR positive disease considered for endocrine refractory cases were enrolled, and it was randomized 2:1 ratio with the investigational arm receiving NR2, that is trastuzumab deruxtecan, 5.4 milligram per kg body weight every 3 weeks, as compared to the standard chemotherapy, that is physician choice chemotherapy, be it capecitabine, eribulin, gemcitabine based or taxane based. And the primary endpoint was PFS with various key other secondary endpoints, that is PFS by BICR, or overall survival in all patients, as well as the HR positive patients, and the safety and the side effect profile. Next slide, please. So these were the patient demographics. We all know that these were very well matched between all the groups, even in the HR positive patients and the all patients groups, irrespective of the age, sex, region, HER2 status, the performance status, and the HR positive status. So they were very well matched and balanced, and no bias was seen in these terms. Next slide. If we talk about the site of metastasis at the baseline, so this was also very important and was very well matched. If we talk about the brain mets, it was almost like near about 5% in both the groups, 6.4 in the NR2 group and the 4.3% in the chemotherapy group. If we talk about lung mets, it was almost 30%, close to 30% in both the groups. And liver also, it was around 70%, two-thirds of the patients in both the groups. So in terms of the vessel mets, especially the brain, lung, and the liver mets, it was very well matched and balanced. Next slide, please. Now, the important thing is the prior lines of therapies, because these kind of patients, once they exhaust the endocrine therapy, especially in the HR positive and the other lines of chemotherapies, how many lines of therapies the patient has received and what all drugs. So that was very important, because that's decide the leading to the advantages of this, like toxicity profile, the frailty of the patient, and the survival benefits. So if we talk about the number of lines of therapy, it was like majority of the patients had more than 3 lines of or equal to, and two-thirds of the patients falls into this category. If we talk about the number of lines of chemotherapy, not only the systemic therapy, then also chemotherapy was almost like more than 1 line in two-thirds of the patients, and more than 2 lines in rest remaining 33% or for around 40% of the patients. If we talk about the HR positive, the number of endocrine therapy in the metastatic settings, so that was equally comparable in both the arms, but it was almost like 1 line in 30%, 2 lines in 33, and the remaining 30%, one-third of the patient had around more than or equal to 3 lines of therapy. Next slide, please. Coming on to the efficacy data, the most important, that is the primary endpoint of the study. If we talk about the progression-free survival, we can clearly see that the curves are very well separated. If we talk about the hazard ratio, it is 0.51, and at almost 1 year, it was like doubling of the median PFS, which was 5.4 months in the chemotherapy arm and 10.1 months in the NR2 arm. So the PFS has almost doubled the hazard ratio of 0.51. So it was the primary endpoint of the study has been achieved. If we talk about the key secondary endpoint, that is the overall survival, because in oncology, the overall survival is very important, especially in breast cancer, where we see the overall survival not too early. So even in that sense, it is seen that the median overall survival was 17.5 months with the chemotherapy and 23.9 months with the trastuzumab deruxtecan. So there was a significant difference of around 6.4 months in between the two groups, and the hazard ratio was 0.64. Next slide, please. So even if we talk about the when the median PFS and the median OS results were reported in all group of patients, there also the similar results were replicated, and what we have seen with the HR positive groups, and the PFS was double, and there was a significant difference, and amounting to a delta of 6.6 months difference in the overall survival with a hazard ratio of 0.64. So we have seen that the PFS and OS benefit in the HR positive group as well as the all patient group. So same results have been replicated in both the groups. And next slide, please. If we talk about this forest plot and the subgroup analysis, then also you can clearly see that all the dots are left to the unity, and we can clearly see that irrespective of the group, be it the prior CDK4/6 inhibitor received or not, ISC status 1+, 2+, prior lines of chemotherapy, age, race, region, and the performance status, and the visceral disease. So the benefit was seen in all the subgroups. The quantum of benefit might differ a bit on the basis of this subgroup, but all the subgroups have been benefited with the use of trastuzumab deruxtecan in HER2 low patients with respect to PFS. Next slide, please. If we talk about the overall response rate, it has almost tripled as compared to chemotherapy in both the HR positive group as well as the HR negative group. So there was no difference in the response rates if we talk about the hormone receptor positivity, whether it was positive or negative. And irrespective of that, the overall response rate have been tripled as compared to the physician choice chemotherapy. Next slide, please. So and if we talk about the reduction in the tumor size, you can clearly see the orange bar graph that the maximum number of patients has achieved reduction in the tumor size, and very few have it is just sizable, very minimal, that have seen progression, and even those who have seen minimal response, they were also stable, whereas in the case of chemotherapy it was not seen, and very few patients had good partial response. Otherwise majority have stable disease or progression. Next slide please. So the exploratory subgroup analysis was also consistent with the trastuzumab deruxtecan efficacy in patient with hormone receptor negative HER2 low metastatic breast cancers. If we talk about the PFS, it was 2.9 months with the chemotherapy as compared to 8.5 months with the trastuzumab deruxtecan. The overall survival was also more than double. It was 8.3 months with the chemotherapy and 18.2 months with the trastuzumab deruxtecan, and which had a hazard ratio of 0.48. Response rate, we have already discussed that overall response rates were almost 3 times. If we talk about CRs, they were comparable. If we talk about partial response, in that case, it was almost 4 times, that is 11% with the chemotherapy and 47% with the trastuzumab deruxtecan. Also, the median duration of response was also doubled, that is 4.9 months as compared to 8.6 months with the NR2. Next slide, please. Coming on to the safety data. Next slide.
Sir, kindly conclude your talk in next 3 minutes.
Yes. So nausea and like vomiting, GI side effects were maximum, but majority of them was grade 1 and grade 2, followed by the myelosuppressive effect, and that was also grade 1 and grade 2, as compared to chemotherapy where neutropenia was very significant. Next slide, please. So we can clearly see that the dose reductions were not very much required, and it was 23% versus 38%. It was more required in the chemotherapy. Dose interruptions was also similar to what we see in chemotherapy. Discontinuation was rates were slightly higher with the NR2, and these were mainly because of rare side effects like ILD, pneumonitis, and peripheral neuropathy, but otherwise it is almost comparable. Next slide, please. Important thing is ILD and pneumonitis to watch over, and especially if it is because once we are aware, then only we can follow. There are specific guidelines how to follow, how to manage them, and I'll not go into the detail. But it is important to note that once the patient has been started on NR2, be very sure that rule out baseline ILD is not there, any other pneumonitis is not there, and follow them quite oftenly and according to the guidelines. Next slide, please. So quality of life. Next slide. That was also comparable, and no major changes was seen. No significant difference was seen from the mean change in the baseline according to the URTC QLQ-C30 scores in terms of overall quality of life, fatigue, and nausea and vomiting, and it was comparable as compared to the physician choice chemotherapy. Next slide. Coming on to the dosing and administration. Next slide. We know that the dose is 5.4 milligram per kg IV infusion every 3 weeks until disease progression or unacceptable toxicity. It is a 90-minute infusion, and further infusions can be given over 30 minutes. Next slide. Dose modifications, there is a set of guidelines for that, and the first dose reduction is at 4.4 milligram per kg. Then the second one is at 3.2. If the patient does not tolerate 3.2, then needs to be permanently discontinued. Next slide. Next slide. Dose modifications for specific ARs. I think these are all very well remunerated in various and most important thing is to remember for ILD. So once the patient has grade 2 or greater than grade 2 ILD, then it needs to be permanently discontinued. Otherwise, for grade 1, there are specific site of guidelines for treatment and management which needs to be followed. Next slide. Similarly, for left ventricular dysfunction, we need to follow the set of guidelines how we follow for the trastuzumab. There is a set of guidelines similarly for NR2 also, and that needs to be carefully observed. Next slide. AE management. Next slide, please. So for nausea and vomiting, it is a very highly emetogenic drug, and we need to follow the 4-drug guideline according to the SKIT classification. It falls into the highly emetogenic. So that needs to be known because trastuzumab is not hematogenetic. So people need to know that this TDXT is highly hematogenetics, and the 4-drug regimen needs to be followed for nausea and vomiting prevention. Next slide. Next slide. I think ILD we have already discussed. Next slide. An expert opinion paper recommends management of ILD and pneumonitis. There is a separate paper for this, and when to discontinue, when to use the immunosuppressive therapy, how to use that, and what are the supportive therapies in the adjunct should be known and followed. Next slide. Next slide. Yeah, so I think these are all related to ILD, and we have already discussed that. Next slide, please. Yeah. So I think just to summarize that for ILD, multidisciplinary team is the key to manage these cases. A detailed patient education program should be facilitated to immediately reporting of these red flag signs so that it can be picked up early and the damage can be reduced. And the patient resources should be handed over to them and educated so that if any NR2 related ILD or pneumonitis is there, it can be reported and diagnosed immediately, and further damage can be reduced. Next slide, please. So this is a case. I think in the interest of time, we can skip the case. We can go to the conclusion slide. So NR2 is the first and only HER2-directed ADC or therapy to provide a significant survival benefit to patients with HER2 low, that is ISC 1 plus or ISC 2 plus with FISH negative in metastatic setting after progression to standard therapies, that is the second line. It has nearly doubled the PFS. The secondary endpoint, the in terms of overall survival, median OS was more than 6 months difference. The response rates are almost 3 times. So yes, definitely it is the standard of care as a second line in HER2 low metastatic breast cancer. Next slide, please. So these are the prescription guidelines. Next slide. And with that, I would like to thank everyone for their patience listening.
Thank you, Dr. Ankit. Very nice presentation on how we really go about using NR2 in these patients and the scientific evidence. Any patient that you've used NR2 and actually it has not been successful, any like 3 plus or a HER2 low?
So I have used in 3 plus only as of now, not used in HER2 low. And till now, I think the responses are very well and they align with what we have seen in the trial world setting. As of now, I would say that it is a very wonderful drug. The response rate and the survival benefits are very, very good. Only thing we need to be cautious about these rare and limited toxicities, which needs to be aware both with the physician as well as the patient, so that that can be avoided, because that can be very debilitating for the patients.
Any experience of ILD?
No.
Okay, not even grade 1.
I think because we are being talking about it very seriously, so the patient selection is very key here. And once we find that yes, this patient has any pulmonary compromise and as a potential candidate for developing ILD, so we are obviously avoiding these kind of therapies for these kind of patients. So I think if patient selection is not there, then we'll land up with these kind of toxicities more often.
Okay. Thank you so much for a very nice presentation.
Thank you.
So we move ahead now and we discuss the role of dual anti-HER2 therapy in breast cancer. And this session is sponsored by Zydus, and we're going to talk about the first biosimilar that has come up for pertuzumab by Zydus, which is called Sigrima. So can I have the next slides, please? So if you talk about the role of pertuzumab, which is the inhibitor of the HER2 receptor or the ERBB2 receptor, and more specifically its dimerization with the ERBB3. We and Specifically talking about the domain, it is domain 2 that it inhibits, and along with trastuzumab, Both combined, we have seen that it has actually changed the way we used to look at the treatment of HER2 positive breast cancer. Next slide. So this is an important cancer, and there is no doubt about it. We cannot really more re-emphasize the fact that most common cancer in females, most common cancer in our OPDs, and probably a cancer which has got a very good survival despite some of the patients coming to know about it in a metastatic stage. Next slide. Equally important for Western population as well as the Indian population, that also is very important. 20 to 25% of these breast cancers are HER2 positive. Next slide. Now, talking about next slide, how the management has evolved over a period of time. So, talking about a time where almost all patients who were early breast cancer were taken up for surgery and then later on subjected to an adjuvant treatment, especially in the HER2 positive space. Now we have the concept of neoadjuvant therapy in early breast cancer, especially in HER2 positive or triple negative population. And there has been ample evidence in the last decade or so to suggest that patients who are at least a stage 2 or a node positive disease, that is stage 2 by virtue of either a node positive or a T2 at least, should be receiving neoadjuvant therapy. And there are other considerations also for a neoadjuvant therapy, be it a younger age at diagnosis or a high tumor volume to breast ratio. So if it is a HER2 positive disease, then a dual anti-HER2 therapy with a trastuzumab plus a pertuzumab is the way to go ahead, rather than only trastuzumab. And we have good clinical data set to suggest and support the same. Next slide. So we have the Neosphere study where these patients who were operable early breast cancer of HER2 positive were randomized to 4 arms, and one of them was pertuzumab plus trastuzumab plus docetaxel for 4 cycles, followed by surgery and then an anthracycline based therapy. PCR being the primary endpoint. Next slide. And PCR was achieved in this particular study, and that is why it was a positive study. If we talk about Trifina study, Trifina had again 3 arms, and there was an option of TCHP, which is trastuzumab plus pertuzumab plus carboplatin and docetaxel, again with PCR being assessed at surgery, but the primary endpoint here was cardiac safety. Next slide. These two trials have showed that there can be a high PCR which can be achieved, or a pathological complete response which can be achieved by a dual anti-HER2 therapy. And this is regardless of hormone receptor status. Of course, no doubt that ERPR negative population would achieve a higher PCR compared to ERPR positive subset, but then ERPR positive subset also had a high PCR achieved and higher than a mono anti-HER2 therapy. Next slide. PCR is something that we are all worrying about or vying for, and the reason for that is that it most of the cases translates to an overall survival benefit. There is no doubt that in a neoadjuvant space, the overall survival benefit with trastuzumab plus pertuzumab combination has not been seen or shown till now. But PCR, higher PCR values are certainly shown, and that is what I spoke about. There is a preference to a non-anthracycline based approach in neoadjuvant space with the BCARG 006 trial that was in the adjuvant setting, and then the later Dutch study of Train 2 showing that there is an equal benefit or an efficacy with a much lesser cardiac toxicity or a better cardiac safety profile. So that is why even the NCCN recommends that a TCH plus a P approach is probably a preferred option for such patients. Next slide. So the future landscape can be with a FER-GAIN study. This study was presented in ASCO 2023, which is again in HER2 positive space, early breast cancer, with a PCR being primary endpoint. There were two groups. The one group which was given only pertuzumab plus trastuzumab based combination along with plus minus endocrine therapy if it was hormone positive for 2 cycles. The other group was a cycle which received all the group which also received chemotherapy, and after that there was a response with a total whole body PET scan. And if the response was there with only a dual anti-HER2 therapy with no chemo, then this was the one which was only continued and there was surgery which was done. Next slide. And it was seen that the PET response after 2 cycles in the no chemotherapy group was about 80%. Next slide. And these patients who were responding, they had a a pathological complete response higher than patients who did receive chemotherapy. So there can be a selective subset of patients who are responding patients where a PCR can be achieved even without chemotherapy. This is future landscape. We do not really follow this as of now, but probably in times to come, or for patients who are frail and not fit for chemotherapy, this approach can be followed. Next slide. Next slide, please. Yeah. So the IDFS and the safety profile tells us that this particular regimen can be followed, but in selective subgroup. Next slide. Next slide, please. So this was about neoadjuvant. Coming to the adjuvant therapy, we have the affinity trial in the adjuvant setting, where it is very clear from the analysis that patients who have got post surgery a profile where we have a node positive subset, and this was the primary endpoint of this trial was IDFS. A node positive subset patients would be the ones which would benefit the most for the addition of pertuzumab to this pertuzumab to the therapy of trastuzumab plus chemotherapy. Next slide. This is one can see that the OS at 8 years, the data is yet to mature enough to find a difference in the overall survival. Next slide. But if we look at the IDFS, especially for the node positive, was a delta of about 5%. And that is what the analysis does suggest, that if the patient is node positive, then the patient should undergo an adjuvant pertuzumab if it has not been received in the neoadjuvant setting, as was the case in the affinity trial. Next slide. It's the same recommendation that is there in as a category 1 recommendation by NCCN as well. Next slide. Now, also, if the patient has received neoadjuvant therapy, which was not there in the affinity study, what about the adjuvant setting? So this is answered by a trial called Peony trial, which was again a phase 3 randomized study, where exactly this was the trial schema for the neoadjuvant setting, pertuzumab being given, and then the pertuzumab being continued in the adjuvant setting as well, irrespective of PCR. Next slide. There were a good number of Asian patients as well, and it was seen that patients who achieved a PCR continuing pertuzumab was not really beneficial. But then if the patients had node positivity in the beginning or PCR was not achieved, which is important to understand, that PCR not being achieved, certainly continuing pertuzumab beyond surgery and in the adjuvant setting did benefit in the forest plot. But if the patient had a PCR but still had a node positive setting in the beginning, that is clinical node positivity, then even the pertuzumab in the adjuvant setting also did benefit, and same is incorporated in the NCCN guidelines as well. Next slide. Next slide. I think we've discussed this. We can go on to the next slide. Next slide, please. Next slide. We can skip this in the interest. In the metastatic setting, we all know about the Cleopatra trial. Next slide, which has shown that there has been a benefit of about 15 months in the overall survival, from 56 months to about 40 months in the study arm and the experimental arm, with the addition of pertuzumab to the baseline of trastuzumab plus chemotherapy. Next slide. And this has stood the test of time, and we've been using it. And there were, the only issue with Cleopatra is that there were not many patients who were brain metastasis positive, that is had brain metastasis in the baseline, and even if they did, about 15% they were treated brain metastasis. For active brain metastasis, this regimen may not still be the go-to regimen, and we have to give a radiation and then do an extracranial disease Cleopatra. But till the time we have the other options available, probably a TDXD coming into the first line, this is the go-to regimen that we have in the first line, with or without brain metastasis. With brain metastasis, radiation, and then continuing with Cleopatra regimen. Next slide. So there are various data sets about trastuzumab plus pertuzumab plus eribulin in the first line, which have been seen this year, as last year ASCO 2024. This was a trial which was presented. Next slide. If you see the PFS here in the eribulin group was 14 months versus 12.9 months in the taxane group. The hazard ratio was 0.95, not significant. OS also not reached. Next slide. But this can be one of the options for patients where we cannot give taxanes for some reason. Destiny Breast 09 is a trial where in the first line HER2 positive MBC, the TDXT is being tried, and that is what I was talking about, that TDXT may trounce pertuzumab in the coming few years if this comes out to be positive. Next slide. But right now, Cleopatra is the way to go ahead, and there is the biggest clinical benefit which has been seen is with Cleopatra. Next slide. So India is now privileged to have the first pertuzumab biosimilar. Next slide. Which comes by the name of Sigrima. There has been a randomized double-blind phase 3 study to evaluate the pharmacokinetics, safety, the efficacy, and the immunogenicity of pertuzumab biosimilar in comparison to pertuzumab, that is Perjeta, in HER2-positive MBC space. Next slide. This was published last year in Breast Cancer Journal in 2024. Next slide. So the conclusion from all this data is that the best space to use pertuzumab and the most convincing data for overall survival is in the metastatic setting, but we do have evidence for the neoadjuvant setting in terms of improving the PCR. We have the evidence in the adjuvant setting in terms of especially the node positive disease, and the PONE data also gives us some confidence that pertuzumab beyond PCR can be given to some patients, especially if PCR has not been achieved, can be given if at all TDM1 is something that a patient cannot afford. There are ongoing researches which may pave the way ahead for newer strategies in future. With this, I thank you all for your patient listening. So I think with this talk on breast cancer, we move ahead and discuss about the management of metastatic urothelial cancers in this panel discussion, which is going to be moderated by Dr. Abhishek Raj. Dr. Abhishek is there?
Yeah, hi, Dr. Rajat. Thank you.
So Dr. Abhishek is our very own Iron Man, and he's here to discuss the urothelial cancer space. And Dr. Abhishek, welcome. Good afternoon. And he's a senior consultant and unit head in the Department of Medical Oncology at Sarvodaya Hospital, Faridabad. Dr. Abhishek, would you please call your panelists?
Yeah, thank you, Dr. Rajat. Thank you for a warm invitation. And yes, I'll see if all the panelists are there. Um Dr. Satyankar is here. He's a senior medical oncologist at American Oncology Institute at Jammu.
Yes,
Dr. Satyankar. Yeah, hi, sir. Dr. Abhishek Yadav. He's principal consultant medical oncology at Yashoda Hospital, Kushambi. Dr. Ankit Agarwal. He's consultant medical oncology at Gitanjali Hospital, Udaipur. Dr. Ulfa Tara. He's assistant professor, Department of Medical Oncology at KIMS, Srinagar, and Dr. Bhavesh Puladia. He's consultant medical oncology at Thangam Cancer Center, Namakkal. Everybody is here?
Yes.
Yeah, okay. So I'll just briefly start with sharing of my slides. If somebody from the organizing team can confirm if my slides are visible.
Yeah, sir, it is
Yeah.
visible.
Okay, so a lot has changed as far as the management of first-line urothelial cancer is concerned. I think most of us, when we started doing our oncology practice, there were just a few options available, and particularly the situation was very dismal for patients who were cisplatin ineligible, particularly even if they were not able to receive even carboplatin because of poor renal dysfunction. So let me start with my case. So here's a 64-year-old male smoker. He's a chronic renal insufficiency with 6 weeks of hematuria. His urine cytology was suggestive of high-grade urothelial carcinoma. It was positive. Cystoscopy was suggestive of 4 centimeter bladder mass. Creatinine was 1.9, and CT scans were performed. So my question, I think most of us are from medical oncology only. So let's start with Dr. Satyankar. So what fraction of patients do you get directly to your clinical practice when you're treating a urothelial cancer patient, sir?
Just about 40 to 50%. Rest they are referred by urologist or some other department.
Okay.
Yeah.
And Dr. Abhishek, Dr. Ankit, you guys are working in a tier 1 city. What's the situation here?
Okay, so we hardly get only 20% patients who come directly to us. 80% usually come through urologist.
Right.
I'll
Dr.
agree with
Ul,
Dr. Yeah, same 20% directly coming to the medical oncology department. Usually, the patients are being referred by a urologist to us.
And Dr. Ulfat and Dr. Bhavesh, what about you?
Yes, sir. We only get 10 to 15%. So the patients first had experiences with urology only.
Yeah, I think I agree. Most of us will say that because majority of these patients they usually present with initial complaints of hematuria. The first referral is always with the urologist. So this was the patient, and I think some imaging was done for this patient. As you can see here on the CT images, there are some bony erosions that are seen in the bones. There are lung metastasis. So let me go back to Dr. Bhavesh. So whenever you are faced with this kind of a patient, how do you proceed further? Is there any other investigations what you want to do whenever you are sitting and discussing with the patients? What are the options you considered when choosing a therapy?
So first, we would like to understand that since it is a metastatic disease, whether the patient will be eligible for cisplatin or not, because that will be the best regimen to go initially. So we'll also like to see the hearing loss, whether it is there or not. How is the cardiac function? Obviously, the creatine clearance will be seen. So all these things needs to be seen before considering starting cisplatin-based therapy. Am I audible?
Anything else you want to do? Yeah, you're audible.
Mhm. Yeah, did you ask anything? Did I miss something?
No, I was asking the same question to Dr. Ulfat.
Okay.
Yes, sir. We do the same, what has been mentioned by my previous colleague. But besides that, we have to see the performance status of the patient as it is a metastatic disease. And since we know that now Bajoran score also we see the site of METs, which is also prognostic now in management of metastatic urothelial carcinoma. Besides that, though, we are not utilizing that in so much in frequently in our practice, but biomarker assessment is also important in metastatic urothelial carcinoma. And certain biomarkers are validated and certain are still ongoing, not validated, but still in research.
So thank you for addressing the elephant in the room. So, Dr. Ankit, what about what about your practice as far as CGP or biomarker testing or PDL1 testing is considered upfront?
So, okay, usually we don't get the biomarker testing upfront. If the patient is cisplatin eligible, we usually go for the chemotherapy management, and then we assess whether the patient has responded or not, and try to include an IO after the chemotherapy protocol is completed as a maintenance therapy. That is what we usually follow here. And as a baseline, we don't usually get the biochemical assessment done. Biomarker we are not doing routinely.
Okay. What about your practice? This is an important question. That's why I'm addressing to everyone. Dr. Abhishek and Dr. Satyankar, is your practice different? Like what fraction of your patients you are doing upfront genetic testing, PDL1 testing, or you're not testing at all?
No, I'm not doing upfront PDL1 testing. Yeah.
I'm also not doing.
Yeah.
So
So I think, sorry. Yeah, please go ahead, Dr. Ankit.
So what we have done for a few patients, if the patient are not eligible for cisplatin, then only we go for biomarker assessment like PDL1.
Correct.
Otherwise, usually we are not doing it if the patient is cisplatin eligible.
Yeah.
Yes,
So
I agree.
yeah, we'll be addressing some of this in the further slides. But I think most of the approvals for first line therapy, it is like not dependent on the biomarker status. Most of the approvals are irrespective of the biomarkers. Even PDL1 testing is not required before initiating therapy, whether it is cisplatin eligible or not. So I agree with that. It goes to the panelists. But yes, if the finances are not a constraint, it's always nice to have a good CGP done even at baseline. But I think you can initiate the therapy without that also. So just quickly moving on to Dr. Satyankar again, what is your definition of cisplatin eligibility and what all tests you do? I think this is something which is very commonly we face.
So basically, we look up to 4-5 things. One, the GFR and baseline hearing loss, and grade 1 peripheral neuropathy is allowed, but not beyond. And we also have to look up the cardiac dysfunction. NYHA 1 or 2 are allowed. So if we have these 4 5 things, then the patient is cisplatin eligible. And
How do you do the GFR assessment? By doing Cockroach?
Cockroach, that formula.
Anybody doing
GFR
that?
more than 60. Yeah.
Or you are taking the cutoff of 60? Everybody's practice is the same, Dr. Abhishek, Dr. Ankit?
Yes, we are taking the same cutoff.
Yes, cisplatin eligible 60. Yes.
Anybody also resorting to, for borderline cases, resorting to your nuclear medicine scans to do the GFR testing for a more accurate analysis?
Yes, especially when the patient has a single kidney, or if the patient has a borderline creatinine value, then we definitely go for a DTP GFR.
Yeah, correct. I think that is also my practice. So Dr. Ulfat, Dr. Bhavesh would like to hear
Yes.
from you also for this.
Yes,
So
we
only
usually we
correct.
go for cograft only in the limited cases where we have constraints of having only one kidney functioning on those. Then only we go for nuclear scan practices.
Only in the borderline cases. Dr. Bhavesh, Dr.
Yes.
Bhavesh is here?
Yes, I am here.
Yeah, hi, Dr. Bhavesh. So your practice is also the same. In some of the cases, you want to do the nuclear medicine scan as well, DTPA.
Yeah, especially when creatinine is going beyond 1.5, I would sort out for a DTPA scan, because usually creatinine of 1.5 and above will bring down the creatine clearance to 60 or below. So
Right.
there we want a more accurate creatine clearance value before starting the therapy.
And what fraction of your patients are cisplatin ineligible for advanced or inoperable cancers to begin with, like
So,
upfront metastatic?
approximately one third of them are ineligible. Luckily, two thirds, or maybe at least up to half of them, are still eligible for cisplatin.
Yeah. So, yeah. So now let me take this question one by one. First, I would like to ask that if the patient is platinum eligible or cisplatin eligible, what will be your treatment of choice? Let's forget about finances. Let's forget about Indian scenario and everything. So when you tell me what is something that you do or what you would like to do if everything is favorable. So starting with Dr. Bhavesh again. Yeah.
So I think if a patient is eligible for cisplatin, then cisplatin plus gemcitabine would be a good choice to start with. We'll try to give 4 to 6 cycles, and then we'll like to put on switch maintenance like avelumab. So that is my usual practice for first line.
Okay.
And similarly, if patient is ineligible for cisplatin but still eligible for carboplatin, then I'll just change cisplatin to carboplatin and follow the same thing.
Okay. If given an option like cisplatin versus carboplatin, what is your preferred regime? Like you are comfortable with carbo or cis? And what does the data suggest? That can we replace carboplatin with cisplatin?
So data we do have a data that we can replace cisplatin and carboplatin, but we err towards cisplatin more than carboplatin.
So I think we'll discuss it in further slides. So let me take this question with others also. Dr. Ulfat, what is your take on this?
So my take is that if cisplatin is always preferable, because there is a data suggesting the superiority of cisplatin over carboplatin, and definitely in terms of OS, PFS, it is always the cisplatin which is better. Only in patients where we are constrained because of cisplatin ineligibility, only then we should give carboplatin.
Dr. Ankit, Dr. Abhishek, any
So I
difference
think
of opinion?
so
Anything else you would like to choose? Nobody for Gemsys Nevo upfront. We've got good data for Gemsys Nevo now. As I said, finances. Let's forget about finances and logistics here, or anything else.
So we have in guidelines like Pembro plus enfortumab vedotin and Nivo Gemsys also, and these trials have also shown better, OS upfront. If you consider Pembro plus enfortumab vedotin, the OS has been good as compared to the versus chemo alone.
Thanks.
And yes, definitely Nivo also with Gemsys and maintenance. However, the trial design was slightly different because in this case they did not go for maintenance as per the response criteria, whether the patient had got response on cisplatin based chemo. But I think in Indian scenario we are still going with the standard of care with cisplatin eligible patients with GemCis and then followed by evolumab maintenance, as the data is quite mature and solid. Yes, Nivo GemCis has also shown better, and this Pembro with enfortumab vedotin, this combination is also better as a category 1 recommendation if we consider.
Dr. Satyankar?
Yeah, basically you need to decide upfront regarding the IO eligibility. If the patient is IO eligible, then the best drug is obviously enfortumab with pembrolizumab, and then next best we have either of Nivo plus Gemcis followed by Nivo for 2 years, or switch maintenance with evolumab. So it all depends on the IO eligibility.
Yeah, Dr. Abhishek, Dr. Abhishek and Ankit, quick word on this again.
Yeah, so if we go by guidelines, sir, then definitely enfortumab vedotin and pembrolizumab is the preferred regime.
Okay.
But then, with cost issues and other issues, if the availability issues are there, then I think gemcitabine cisplatin or gemcitabine carboplatin followed by avelumab will be my next choice. As far as nivolumab in combination with gemcitabine and cisplatin, I am not very much convinced with that trial. So I would go with the gemcis or gemcarb followed by avelumab maintenance more in a more keen way than going for nivogemcis.
Okay. So we'll discuss briefly about one of the pitfalls of major study going ahead. Dr. Ankit, you are left. Your take on this.
Okay, I totally agree with Dr. Abhishek. So, Nevo plus Gems is, I don't know, it's not convincing, although uh, um, it has been included in NCCN as category 1, but probably using upfront IO with a chemo is not very convincing in this as the data is concerned. So I usually go for Gems is followed by Evolumab as switch maintenance, and Pembro plus enfortumab vedotin is a very good option. Yes, it's a good option. The only thing I would want to use enfortumab vedotin as a second line, which is probably I am more interested in using enfortumab vedotin as a second line. I would definitely give chemo in the first line if the patient is eligible for cisplatin.
What about cisplatin ineligible? What is your treatment of choice? Let's say
So,
it's carboplatin ineligible also.
then Pembro plus enfortumab vedotin is a very good option for that patient.
Okay.
If the patient is not eligible for platinum.
And what about others? I think nobody has addressed the cisplatin ineligible patient. Dr. Bhavesh again, Dr.
So I
Ulfar.
think if patient is platinum ineligible, then directly we can go for Pembro EV combination.
If Pembro EV, like right now, I think most of us are not using Pembro EV. What is your treatment of choice otherwise? I think
Then it will be a single agent Pembro, or if we have a good PDL1 positivity, then Atizo.
very nicely summarized, sir. I think this is what I think most of us will agree also, that if that is not the case, we have data for single agent Pembro. For I think IC2 and IC3, we have data for Atizo single agent. So I think most of this, anybody using this MVAC, I think most of us, when we started our practice, this MVAC must be there in picture. Any data to say that it is superior or the same?
So there was a data in the as far as I remember, there was a data in the neoadjuvant setting. I'm not very sure about the metastatic setting, the Vesper trial, that had shown superiority of dose dense MVAC versus Gemcis. But I am not using it in metastatic setting. Gemcis is a very good option for metastatic setting, I think.
I think most of us won't be using MVAC because of its higher toxicity, higher rates of febrile neutropenia that has also been addressed in the many clinical trials. So this is the treatment landscape for metastatic urothelial cancer. We've had gemcitabine and platinum for a long time. Then I think the first drug was atezolizumab, and then I think there was also a trial of chemo plus atezo. Somehow, as the data matured, FDA with the approval for atezolizumab in combination with chemo in cisplatin eligible patient, I think the withdrawal was there in 2022. But this was the first IO that was approved in urothelial cancer. I have a couple of patients who are doing very well on Atizo for more than 2 years now. So I still don't think that Atizo has completely gone out of picture in this scenario. But then you can see that there are a lot of drugs which led to the which were approved after 2017. Now we have data for ADCs, and I think last year ASCO GU update, one of the best presentation was for your EV Pembro data, very promising data. If given an option, I would probably choose this for almost all comer patients, whether it is cisplatin eligible or ineligible. So I think it is now more about sequencing, identifying, as all of you have discussed, that first we identify the eligibility for cisplatin as well as the eligibility for IO. And based on that, we decide our treatment. And when the patient progresses, I think we can go opt for a NGS or something, and then we can choose our targeted therapy. So this is the NCCN guidelines downloaded today morning only. As you can see here, now it's a preferred and a category 1 regime, as everybody else mentioned. Also, I think Dr. Ankit was mentioning gemcitabine cisplatin followed by evolumab, and nivo gemcis is also a category 1 recommendation. But there is no head-to-head comparison of upfront IO versus upfront chemo followed by maintenance. And for cisplatin eligible also, this is the so we were trying to address that GEMSIS versus MVAC. So this is the data that there was no difference in the median OS, as you can see, that the curves are not separating, but the toxicity is higher as well as toxic death rate is higher as compared to GEMSIS for MVAC. Although the curves start to see, it seems a little separate, but the p-value is not significant. If we talk about in non-metastatic settings, cisplatin is definitely proven to be superior. In a metastatic setting, you can easily replace carbo with cisplatin. There is data that it is a non-inferior, so you can use gem carbo as compared to cisplatin based on this URTC 30986 study. There is absolutely no difference either in median OS or even in the response rates. So this was Keynote 052. It was published in, I think, based on this data, I think most of us are using pembrolizumab in the cisplatin ineligible patient. It was a phase 2 study, which led to the approval of pembrolizumab in all comer patients. The benefits was particularly more pronounced in patients with CPS more than 10. So quickly, a quick word from all of the panelists about Keynote 367. What do you think was the problem with the design of the trial? This is the curve. As you can see here, this is the difference in the PFS, difference in the OS. Numbers look slightly promising, but what do you think? Why did this trial fail? Starting with Dr. Satyankar. So this was a trial which stratified patients who were treatment naive to Pembro Gemcis versus Pembro alone versus Gemcis or gem carbo for 6 cycles, and Pembro maintenance was given. So quick word, Dr. Satyankar, you can start. You can
Can't say. I haven't gone through this trial.
Okay, sir.
But
Anybody, any panelist?
Different, patient population or something.
I think in the intention to treat population, there was no difference in the significant difference was not seen.
Yeah, so it did not reach the margin of superiority. If you see the Gemcis avelumab trial, had this trial been designed that you give chemo to all comer patients, so you can see that initially curves are not separating, and it is only after 6 months that these curves have started to separate. So if the randomization would have been done here, maybe Pembro would have come in as a maintenance, like we have a data for avelumab. So the data for pembrolizumab, had the randomization been done here, maybe this trial would have shown slight significance. So that's probably something to do with the trial design rather than the drug itself. So we've discussed briefly about the ATIZO data, IMvigor data, that the benefit was most pronounced in patients who had high PD-L1 score. As you can see, the patients with high PD-L1 score, they have a hazard ratio of 0.68 in cisplatin ineligible patient upfront as compared to your placebo plus gem. So quick word on EV302. Again, any takers for EV302 versus your traditional approach of Javelin bladder trial? Dr. Ankit.
Only concerned about the toxicity, nothing else. Otherwise, it's a very good new drug to try out. I've not used it.
What are the toxicities you'll be worried about if you're counseling your patient for initiating the patient on this ADC? What will be your concern to the patient?
So probably hyperglycemia, then some ocular toxicities that has been mentioned. orbital cellulitis, ocular toxicities have been mentioned, hyperglycemias, and related to some new dermatological toxicities that have come up because of enfortumab. Probably that is the only thing. And once we use it personally, then only probably we'll get to know what exactly is the grade of these toxicities. Though
Anybody
probably
use this? Anyone among the panel have used Partsiv?
No, no,
No.
we haven't.
Okay. I recently initiated one patient on Padcev with Pembro. Uh, he's received 2 cycles. I think it is going to be launched by Astellas Pharma's next month. They're planning to launch it next month. So we got it imported. The patient is doing well. Fortunately, no toxicity. He was a good performance status upfront metastatic disease. We'll see how it goes.
so
So,
how did you counsel your patient about the toxicity, sir? Any new counsel, any
apart from the skin toxicity, it is also important to counsel about the neuropathy.
Neuropathy.
Neuropathy is
Okay.
quite common with this, as we have seen with even Brentuxi also. Like Brentuxi also causes neuropathy. So that is one concern. So patients with poorly controlled diabetes and all, you have to be really careful. Probably start with a lower dose and then only escalate it rather than just using the trial dose, because it is always wiser whenever we are using a new drug
new
which
drug?
is familiar. I think start with a lower dose and then escalate it. Uh,
Absolutely.
Excellent PFS curves. You can see here that the PFS curves are starting to separate as early as 2 months, and they are separating, and this separation is maintained as the follow-up has gone on. And if you look at the subgroups also, I think majority of the subgroups, they are benefiting. So just returning back to the case, so this patient did not have access to the beautiful Padcev and pembrolizumab. So he was started with gemcitabine carboplatin. He was at least carboplatin eligible. CT scan showed some partial response. What would you like to do next? Starting again with Dr. Bhavesh. At this point, what will be
This
your...
is a patient who has shown response to chemotherapy. So this will be definitely eligible for a avelumab maintenance, switch maintenance.
Right. Everybody will agree, Dr. Ulfa, Dr.
Yes.
Yes, yes.
Yes. Evolumab maintenance.
Okay. How is everybody's experience with avelumab? What are the best candidates for avelumab if we look at the Javelin bladder trial? Are there any subset of patients where you are very, very like particular that okay, please take avelumab, this is going to make a big difference to you?
I think especially patient with stable disease would be something where I would like to push them for some kind of therapy, avelumab maintenance for sure.
Dr. Abhishek, Dr. Satyankar?
I agree with Dr. Bhavesh. Yeah, it has to be stable disease or a PR.
Dr. Abhishek, your take?
Yes, sir. Any kind of stable disease or response, partial response
I think
will do.
very interestingly, those patients who had a complete response to chemo, they when they took avelumab had a very good survival. I don't know whether it was the effect of chemo or it was the effect of maintenance in avelumab.
I think there was a follow-up data or the update of this Javelin bladder trial published. The patients who had CR or near CR, agree with Dr. Ankit, they went on to have a median survival of around 40 months, 42 months also. So those are your patients which like who have had excellent response to chemo. There I am very particular that you should probably take avelumab because in our practice it is very costly drug and often out of reach of pocket of most of our patients, but there are certain subset of patients where you really like to emphasize, although the approval is definitely there for all comer patients. It's just data that I was trying to share, which Dr. Ankit rightly mentioned, that the patients who had CR or near CR are the ones who benefit the most.
Very interestingly, avelumab has only been given in maintenance therapy, probably because it is a 2 weekly regimen. How do you manage giving it in with chemotherapy? Very, I don't know. It's just something to ponder about.
With chemo, you don't have to give.
Exactly. That's why, because it's a every 14 days therapy. So
Yeah.
GEM says it's not, you cannot call your patients every 7 days to give chemo and
Patient will be in the clinic every week.
exactly. So I don't know. Probably that is one reason why avelumab was not given along with GEM says. I don't know.
No, I would like to differ here. Basically, so far the data for chemo and IO, basically all of the data as far as concurrent IO with chemo, um, starting that, it has not shown a benefit as of now. It is the maintenance part which is, showing the benefit with IO. Because the trial design of what we were discussing, the Pembro, upfront with GEMSIS, the trial design was faulty at this point also because they started upfront concurrent. As we know, the IO response we get usually delayed. And then they continued this irrespective of whether the patients had cisplatin response or not. They continued the maintenance. And the trial design was faulty, and that was a negative trial.
So I think these guys were wiser. I think it is by Merck, right? That after you select out a good patient, the patients who have had response only give the IO to those patients and derive some benefit. So yes, most of the patients who have initiated initially on IO plus chemo, there will be a good subset of 30% odd patients who might have had primary response as a progression. So of course that may have brought down the result of those pembro maintenance or even atezor trial that was there initially in combination with chemo. So anyways, this was the Javelin bladder trial. Most of us know about it. You can see here that the median OS was 21 months versus 14 months after the maintenance was given. Sorry. Okay. So on a long-term follow-up, again, if you start from the starting of first-line chemotherapy after censoring the patients which were not eligible, so this difference is maintained with a 23% reduction in the risk of death. So this patient, he receives avelumab maintenance for 6 cycles. You do an interim CT scan, it shows new lung nodule concerning for metastasis. At this point, I think everybody will agree that they would like to go for NGS.
Yeah.
Yeah, so this was as Dr. Ankit advised this patient to do NGS, and this was the result of the NGS. So, Dr. Ulfat, what will you do here?
Now we are not getting any targetable, for the target drugs, what we have now in hand, like HER2 or TROP-T. We have already given avelumab maintenance also for 6 cycles. Then we have to change the treatment part now at this stage, but we don't have, this is TP53 positive.
Yeah.
Again, it means that this patient will be bad prognostic subtype, and we have no FGFR abnormality also detected. So as far as NGS panel is concerned, so we don't have any targetable. I mean, for HER2.
What will you opt here for the patient?
We opt for
this particular case is received gemcarbo and then avelumab.
Yes, we can go for second line IO also. There is some data also for that also.
Dr. Bhavesh? Yes, pembro is an option, ma'am. Yeah, correct. But I think it's doubtful that whether the patients will respond after exposure to avelumab.
Already avelumab.
Dr. Bhavesh, your take? I couldn't get you properly. I think there is some network issue. So, Dr. Ankit, your take?
EV is a good option for this guy currently. I think enfortumab vedotin.
I think we've not used EV here. We have, I think the trial was EV 301, which led to the approval of EV Pembro in the second line, and then it gradually moved to first line after EV 302. And apart from that, I think the patient has already progressed on immunotherapy. If EV Pembro is not an option, we'll have to probably go for something like a paclitaxel. We have data for vinflunin. I don't think anybody of us would have used. I've also utilized oral methotrexate or metronomic in some patients. I think few patients do respond briefly to these metronomic. But apart from that, the situation is dismal if you don't have an access to some of these newer drugs.
KDM6A mutation unlikely to respond to enfortumab.
Which one?
KDM6A mutation very unlikely to respond to enfortumab vedotin.
Okay, I'm not aware about this data. Was there a
Now this is the
subsequent?
data which came out later on from the EV trial
Mhm.
that patients who are TP53 and KDM6A mutated,
Mm.
they are the ones who don't show much response to enfortumab vedotin. So I think that will not be an option for this patient.
So Dr. Rajat has a question for you, Dr. Abhishek. That what if FGFR2 was mutant in NGS? Anybody can take this.
Erdafitinib can be given.
Erdafitinib.
Yeah,
Two and three, both I think we can use erdafitinib.
Yeah.
It is a pan.
absolutely.
Okay. So I'll quickly show that trial.
So I think, can I come in?
Yeah, please.
Yeah, so
Your confidence is that.
basically, why this is important is that number one, FGFR2 inhibitor, erdafitinib is an it's an FGFR3 inhibitor. It's not an FGFR2 inhibitor. So FGFR3 fusions are the most common that one would assume and would like to see in the NGS. That is one. So it is not a 2 inhibitor, and 2 generally we don't get also in metastatic urothelial carcinoma. That is one. But the important point here is to understand is that there is a study called Thor study, which has actually led to the, I think this is what we're talking about, Thor studies, what is there on the screen right now. So led to the approval of erdafitinib. This was post IO. So this was chemotherapy and IO both had to be given. So of course it did not talk about avelumab maintenance. So when we have given avelumab maintenance and of course a gemcitabine based therapy in the beginning, so chemo and IO already has been used. So here one can really resort to an erdafitinib. But if at all immunotherapy has not been given, the guidelines recommend that chemo and immunotherapy should have been given before we go on to venture into a EV or a FGFR3 inhibitor. So the two E's, that is EV or erdafitinib, is post chemo plus chemo and IO in that order. And since in this case that Dr. Abhishek has presented, both have been given, so FGFR3 alteration is or fusion is there, erdafitinib. If it is not there, then EV can be one of the options. What Dr. Abhishek is talking about, the mutation part, I'm not aware. If at all that is the case, then maybe EV shouldn't be given and taxane should be resorted to.
So this was the EV301 study, sir. So the patient had to have progression on just platinum-based chemotherapy. It was not mandatory that patient also had progression on IO, sir. So if patient progresses on first line chemo also, he would be eligible for EV, sir.
This is 301 that you're talking about, no?
301. So if we are talking about the usage of EV in second line, sir.
Yeah. So it says after platinum and anti-PD1 therapy.
Oh, relapse on or after. Yeah, sorry. Okay.
Yeah. So 2 lines had to be given. 301 was post 2 lines, and this was EV monotherapy. This was not with Keytruda. EV with Keytruda has been
It is EV monotherapy.
yeah, EV with Keytruda is only in the first line, 302 that you were talking about.
Yeah. So basically, considering how good this drug is, if suppose the patient has progressed on Gemsys in a real world scenario, I know the guidelines are not there, but given an option, if you have an access to both the drugs for second line, I think most of us would like to use the combination there also, even though we don't have a well-defined guidelines.
Yeah, I agree. We can use, but then I mean as of now the sequence is this. But then I do agree that if the drug has come in the first line, then probably we can use it in the second line also.
True. So I think we have had quite an interesting discussion. And, so this is all. I think just a brief word about the usage of sacituzumab. Anybody use this drug? I have used it in one patient a couple of years back. Uh, So this patient was progressor on 3 lines, and we did not have a good time with him. So I think we gave for two cycles, and he landed up with bad febrile neutropenia. Probably heavily pre-treated patient, and we lost that patient. Anybody else is whose experience is there with using Trodelvy in urothelial cancer? Any patient?
Not used.
Okay. It's probably not one of the best ADCs out there. We've got some excellent ADCs. It's probably not one of the best. Dr. Rajat, any experience with using Trodelvy, sir? Anywhere in
No, no, no.
or
So
anywhere?
Delvi only in triple negative I've used in two patients,
Okay.
but
How
not
was the
in.
experience with the toxicity and
So
all?
so not very toxic. It was tolerated well. One patient responded, the other did not. The one who responded was a young lady, about 38-year-old, post 2 lines of therapy. She responded for approximately 4 to 5 months. That is what the PFS was. The other patient did not respond at all. Metastatic urothelial cancer, I have not used.
Okay, I think we've discussed a lot. And returning to the scale, this patient actually he was started on enfortumab vedotin. He tolerated the therapy with some grade 2 neuropathy, and he continues the therapy even today. With that, I'll conclude my session. And thank you again, organizers. Thank you, Dr. Rajat, for inviting, and thank you all my panelists for a wonderful discussion. And with that, I'll conclude this session. Thank you.
Thank you.
Thank you. Thank you.
Thank you very much once again, everybody, Dr. Abhishek Raj, and everyone in the panel who contributed and gave their own inputs. Just a last thing about erdafitinib. I have used erdafitinib in two patients, and these were post 2 lines. FGFR3 mutation fusion came out to be positive, and very bad performance status, nearly like, I would say that there was no hope left. They were in search of this drug for say about a month and a half. Then they finally procured it. Both these patients have miraculously improved. There is no other word than using this miracle word for them. And within about 8 to 10 days, the patient who had an extensive lung metastasis, breathlessness, oxygen dependent, the oxygen was off, cough disappeared, breathlessness has disappeared. This is about 8 to 10 days. Nothing worked in these patients. Nothing will work. So gave gem, gave Pacli, gave nivolumab, and there was a progression on treatment. So I mean, there was not even a one PET scan where I could say that there was some improvement. And a young guy, this is just like 35, 36-year-old. This is one patient. The other patient is about a 45-year-old. Again, there has been a miraculous improvement. So if we can get hold of these drugs, I mean, all of us are aware that things improve. But then these drugs are not that easy to get. Dr. Satyankar is talking about NHER2 also being difficult to afford for a lot of patients. So I think that is the issue as far as the cost is concerned for medical oncologists. But these are good drugs, there's no doubt about it. So I again thank you all for joining in this afternoon on Sunday to discuss these important topics. And with this, I think we come to the end of this webinar today. Uh, there was a good contribution by all the learned oncologists from all over the country to talk about the important topics. We've learned a lot. I have learned a lot. I think everybody who attended has actually had something to give to their patients from tomorrow morning. This is what the intention of doing these webinars is. I thank you again, all of you, for giving your time and inputs. I thank the people at Horizons for their seamless contribution to go about doing this webinar. I thank the pharma people for backing us. And with this, I say a goodbye to all of you and have a great evening ahead. Thank you.
Thank you.
Till we meet again.